Good morning, ladies and gentlemen. I'd like to bring the meeting to order. We'll still have a few people coming in, I think, for a few minutes, but I'd like to get started. We've got a fairly tight program this morning with a full content, so we want to keep on time. My name is Bruce Clark. I'm one of the members of the Canadian Spondylitis Association, the sponsor of this day's events, and I'd just like to give you a brief history of the Canadian Spondylitis Association. Going back many years ago, probably 30 years ago, there were a group of people in British Columbia that began with a patient support group for people with spondylitis, and Mr. Andrew Hobbs, sitting in the front, was one of those people. Dr. Andrew Chalmers was another person. So there were several people who originally got together and developed and Ann Riddick, sitting at this table, was one of those people. And so we developed in British Columbia a group that put out a newsletter 4 times a year, put on speakers perhaps 4 times a year, and had various other things. For a while we got together at swimming pools and did exercises together and tried to provide a network for people with spondylitis. The same thing was happening in Ontario, and they had a very strong group in Ontario. There were some physicians, Dr. Little and various people who had special interest in spondylitis. And then along the way, going back about 6 years ago, a couple of people in Toronto and a couple of people out here, we said, this is all very well if you have spondylitis in Vancouver and you have spondylitis in Toronto, but what if you have spondylitis in Moose Jaw or Newfoundland or Prince Edward Island or somewhere? And so we decided that in the best interest of all of the people across the country with spondylitis, we probably should form a Canadian Spondylitis Association. So about 5 years ago, we got together and developed the Canadian Spondylitis Association, which has come into being. And so we're a national organization. And paralleling us, there has been you'll see a name that is SpA. You've probably seen that on a number of things. That is the Spondylitis Research Consortium of Canada. And it consists of rheumatologists across the country who have a special interest in doing research and finding causes and cures and whatever in the spondyloarthropathies, including ankylosing spondylitis and psoriatic arthritis and 3 or 4 other varieties in this family. So while the physicians have been working as an entity across the country, and I might say they're a pretty stellar group of people. There are people in this community, there are people in Edmonton, Toronto, Newfoundland, and they've done some pretty impressive work, and they collaborate commonly with people in the United States, people in Germany, people in Holland, people in England, and further afield. And there's been a lot of genetic discoveries made. Most people in the room know about HLA-B27, but as time has gone by, there have been other genetic factors that either contribute to the development of this, or there may be other factors that preclude you from getting it. And I'm not sure whether one of our speakers this morning will be addressing that or not. So the Canadian Spondylitis Association, as a national body, appreciating that we're not going to get together for meetings too often, we had a meeting in Toronto about 6 weeks ago, and we've got this meeting here today. But on an ongoing basis during the year, we're going to try and do much of the work through a website. So if you go to the website now, spondylitis.ca, you may be less than impressed this week because it isn't where we want it to be yet. But the content is improving, and we're going to be adding to it quite dramatically over the next 6 months or so, and putting more resources into the development of that website. And if you want to have discussions with other individuals with spondylitis, there is also, from the spondylitis website, you may choose to go to the Facebook page, and there is a spondylitis Facebook page. And right now we've got about 1,000 members in the Canadian Spondylitis Association and about 250 people who are regularly visiting the Facebook page. And so when I went in there yesterday, there was somebody posing a question. It was a woman, as I recall, and she was talking about having pain in her chest around the ribs, and was essentially saying, I'm having trouble in this regard. Does anybody, does this make sense? Is this something that we get? So it provides a forum that people can interchange with others. And so I invite you to look at the Canadian Spondylitis Association website. I have a little reservation in that 6 months from now it's going to be a much bigger site than it is now. Today's forum is being videotaped, and so the presentations from today will finish up on the website, so that if you happen to live in Fort St. John and BC and you can't get here today, or you're in Campbell River or wherever, you'll be able to access these presentations later. And if you want to see the presentations by Dr. Inman and other people that were done in Toronto 6 weeks ago, you'll be able to see those things as well. So that's a synopsis of the Canadian Spondylitis Association. There is no membership fee. We've been fortunate that we've had sponsorship from industry and various people that have enabled us to function without charging a membership fee, and so we hope to continue in that vein. So I'd like to get on with the program now, and our first speaker of the morning is Dr. Kathy Flanagan, who is a rheumatologist in the Lower Mainland. She is also a member of the Spondylitis Research Consortium of Canada, SpA, and she's a clinical instructor in the Faculty of Medicine at UBC. And her title this morning is Current Concepts on Ankylosing Spondylitis, Recent Advances in the Battle of an Old Disease. Dr. Flanagan.
As probably everyone knows, there has been an annual meeting of SPARC, which has been held in different areas across the country. And we were actually supposed to have one in Vancouver, I think, 2 years ago, and that didn't happen. So for the first time this year, they decided to have 2 days, one in Toronto and one in Vancouver. So this is why we're ending up 6 weeks after the annual meeting in Toronto. We're having one here. Okay, so just let me go back for a minute. This was a picture, actually, of Vancouver in the fog that was taken from Cyprus. So if anybody's wondering what that is. All right, so I was asked to do a sort of an overview, and I'm not going to be really comprehensive because there's just so much to talk about, but I'm going to talk about some of the issues that have come up in the last couple of years that have been of a lot of interest to SPARC, as well as to obviously patients with spondyloarthropathy. And these are some of the things that are being actively researched and looked at across Canada as well. So when we talk about spondyloarthritis, or SpA, which is the term that we often use, it comprises a number of different diseases, as you can see here. And Dr. Keeler is going to be talking a bit about psoriatic arthritis. So I'm talking mainly about ankylosing spondylitis, but we'll include some of the other things in here as well. It's kind of difficult to use the pointer here because the way it's angled, so I can't really do that. But you can see here that psoriatic arthritis is part of this, acute anterior uveitis, which can occur on its own or in association with any of these diseases. Reactive arthritis, which occurs usually after infections, which are either usually urogenital or gastrointestinal. The diseases that occur with inflammatory bowel disease, whether it's Crohn's or ulcerative colitis. And then there are juvenile forms of spondyloarthropathy, which can be exactly like the adult ones, but also have some differences. Okay, so in terms of the characteristic parameters that we use for diagnosis, as I mentioned, symptoms are obviously very important, and I'll describe the inflammatory back pain first. But we also have what's called dactylitis, which is inflammation of all the tendons around a digit. We usually call it sausage, finger, or toe, colloquially. There's also something called enthesitis, which is inflammation where tendons join onto bone, most often in the Achilles tendon, so the back of the heel, or the plantar fascia on the bottom of the foot. In terms of imaging, their x-rays obviously are used, particularly of the sacroiliac joints, which are the joints obviously where the spine joins onto the pelvis, as well as the spine itself, and can involve the whole spine. And more recently, there's been a lot of focus on MRIs. We sometimes use CTs as well, but MRIs in particular. One of the issues we have here in BC is the access to MRI. It takes us on average about a year to get an MRI. So that is an issue for us, and that's across Canada, but it's particularly bad in BC. In terms of laboratory tests, we don't really have any good biomarkers such as they have in rheumatoid arthritis. We use the sedimentation rate and C-reactive protein, but they're very non-specific. They go up with any inflammation, and unfortunately, they're often not elevated in people with spondyloarthropathy, so it makes it a little bit difficult. We don't have a really good blood test. And then in terms of their history, sometimes people will have a family history, but another one is good response to anti-inflammatories. The issue with that is that we see that with lots of different forms of back pain, so it's not very specific. Okay, genetics, as was mentioned, and I'm not going to go into a lot of detail because it's complicated and for lack of time, but the HLA-B27 is a blood test we do. It's a genetic marker, which is very common in particularly ankylosing spondylitis. But it also is seen in the general population. So in and of itself, it isn't 100% specific. And as I mentioned, family history. And we always look for family history of things like psoriasis as well as inflammatory bowel disease. Predisposing or concomitant diseases, as I mentioned, infection, which is usually either gastrointestinal or urogenital, can occur with what we call reactive arthritis. Psoriasis, as I mentioned, and Crohn's disease, also ulcerative colitis, but particularly Crohn's, which is a form of inflammatory bowel disease, and uveitis. And we have Dr. Sexton will be talking about uveitis later in the morning. When we talk about what we describe as EAMs, or extra-articular manifestations in spondyloarthritis, as I mentioned, so the eye, skin, and gut, as we mentioned, they're common. So they occur in about anywhere between 20 and 60% of patients at some point will develop what we call extra-articular manifestations. And they can occur before the onset of arthritis, during, or after. As I said, these things are related to inflammation of different parts of the body. We have other areas that are affected as well that are not directly related to inflammation, but you can certainly have involvement in the lungs, the kidneys, the heart, and the nerves. Fortunately, those are all very rare. Most of them are subclinical and usually occur with long-standing and more severe disease. So we don't see them that often, but they do occur. So this was actually an interesting study where this was in Germany, where they took about 850 patients. And at the beginning, they looked at who had extra-articular manifestations. So about 60% of the patients didn't have any, and 42% had some at some point, whether it was at the moment, had some in the past. And when they followed them along, they found that about half of them had anterior uveitis, which is inflammation in the eyes, we'll hear about later. But 20% of them had psoriasis. Approximately 20% had some form of inflammatory bowel disease, and another 10% had a mixture of any of these. So these are common manifestations. So recently there's been a lot of discussion about how we classify this, what's called spondyloarthritis or spondyloarthritidity. And there's what's called predominantly axial, which means basically in the spine, versus peripheral. So this would be joints other than the spine, which particularly in ankylosing spondylitis tends to be the larger joints like the knees or the hips, and sometimes the shoulders, not typically the small joints such as we see with rheumatoid arthritis. And reactive arthritis and psoriatic arthritis have more peripheral arthritis than ankylosing spondylitis typically does. One of the big issues in spondyloarthritis has been the fact that it's been difficult sometimes to make a diagnosis because there's what's described as a non-radiographic stage. So people can go for quite a period of time where the x-rays will be normal even though they have significant symptoms. So it's been hard sometimes to be able to make a diagnosis. And the criteria that were used to make a diagnosis in the past were called the modified New York criteria. And I'll just, but they included, and I'll talk about that in a minute, you had to have a positive x-ray in order to be able to be diagnosed. The issue is that the average delay in diagnosis is somewhere around 9 years between the onset of symptoms and the first diagnosis. That has always traditionally been the case. So, and again, with relatively nonspecific symptoms and no really good blood tests, if your x-ray was negative, it was very hard to make a diagnosis and therefore give you appropriate treatment and so on. This is, as I mentioned, these are the modified New York criteria. And so you can see that the symptoms are fairly nonspecific. Low back pain and stiffness, which had to be for at least 3 months, which would improve with exercise, but not relieved by rest. This is different from what we call mechanical pain. So if you had a disc, for example, or you had sprained your back, usually you would be worse with activity and better with rest. So this is sort of the opposite. Limitation of motion of the spine, but again, not all that specific, because you can certainly have that if you have mechanical pain. In the x-rays, you had to have inflammation in the sacroiliac joints, which was fairly significant. And as I said, that can take quite a long time before you can actually see that on an x-ray. So this is just, I won't bore you with the details, but this is just very mild symptoms, this is a person who may have symptoms but has a normal x-ray, and this is one where there is inflammation in the joints with changes where we could definitely make a diagnosis, but this might take up to 10 years before it would happen. So in the last couple of years, there was a reclassification done in an effort to try to address this and try to see if we could make diagnoses earlier and therefore access treatment earlier, because as everyone knows, we now have very effective treatment for these diseases. So what they did in this situation is, the caveat is that this has to be in patients that have at least 3 months of back pain and the age of onset. That doesn't mean when they were actually seen or diagnosed, but when they first developed symptoms of under the age of 45. So in that setting, these are the proposed diagnostic criteria. So you can see on the left, again, unfortunately I can't really use a pointer, but on the left, this is very similar to what we saw with the New York criteria. This is when you have inflammation in the presence of changes on the x-ray. And that's pretty easy to see. Anyone can make that diagnosis. And we talk about the SpA features, and those are all listed there, and I'll talk a little bit more about that in a minute. But it was also proposed that you could make a diagnosis in a patient with this back pain who was HLA-B27 positive, so this is the blood test we were talking about, plus they had to have at least 2 other features, but they could have a completely normal x-ray. So this is quite a different look at it, and it enables us to make earlier diagnoses. And when we're talking about imaging, we're talking not just x-rays, we're also talking about CT scans and MRIs, which are often positive earlier than an x-ray. So we may be able to see changes on an MRI with a normal x-ray. So you can certainly make the diagnosis if you have a positive MRI, but you can even make it in the setting of a normal MRI or x-ray. Right? So as I mentioned, so when we talk about inflammatory back pain as opposed to mechanical pain, these are the criteria. And you basically have to have 4 out of these 5 criteria. So age of onset under the age of 40. Insidious onset, so it's not an acute onset like you would normally see, for example, if you had a disc or you pulled your back. Although we do not uncommonly see patients presenting with the first onset after an injury. So this is not entirely, you can't sort of hang your hat completely on this, but usually they'll have had some history of a gradual onset. Improvement with exercise, as I mentioned, is very important. Patients typically have their worst pain in the middle of the night or very early in the morning. It will often wake them up, and they have a lot of discomfort and stiffness in particular in the morning. And characteristically, the stiffness is for at least an hour, half an hour to an hour. A lot of people who have degenerative disc disease, for example, which happens as we get older, will have 5 or 10, maybe 15 minutes of stiffness in the morning. But if it's a lot longer than that, it's much more suggestive that this is inflammation. And as I mentioned, the pain at night, not just as someone's going to sleep, but usually after the middle of the night, so early in the morning, very typically. So patients have to get up because they are in so much discomfort. In terms of arthritis, it can be either past or present active inflammation in the joints. As I mentioned, mainly with ankylosing spondylitis, it's the knees, hips, and shoulders that would be affected, and sometimes the ankles. So this is the positive family history. So this has to be in a first or second degree relative, and they could have had either ankylosing spondylitis, psoriasis or psoriatic arthritis, uveitis, as we mentioned, reactive arthritis, or inflammatory bowel disease. All of those would be considered to be a positive family history. Psoriasis, as I mentioned, it could be past or present, but it has to have been diagnosed by a doctor. It can't just be someone thinks that that's what they had. Same thing with inflammatory bowel disease, the dactylitis, as I mentioned, the sausage finger or toe, the enthesitis, mainly in the heel, as we were saying, or the foot, the anterior uveitis, which again is past or present. The good response to anti-inflammatories is a little bit less specific because, again, whatever your cause of back pain, you can have a pretty good response. The HLA-B27, as I mentioned, and we can do that through BC Bio fairly easily here. The elevated C-reactive protein is, we mentioned, with inflammation, but often patients can have a normal CRP, so that isn't a very specific test. As we mentioned, the sacroiliitis either by x-rays or by MRI. And we also accept it on a bone scan or on a CT. So just in terms of making the MRI, there are some very specific criteria that are used, and we've gotten much better. Dr. Maximovich in Edmonton has done a lot of work around the world trying to standardize the criteria for diagnosis. He's done a really excellent job, and so now we're having more and more radiologists being able to make good diagnoses on MRI. But again, our issue is more access than anything else. And just to show you, there's just those white spots there, there's inflammation on the MRI. So in terms of screening somebody who's coming to you with chronic low back pain, once again, it's important to say that this is for at least 3 months. That really rules out most of the acute cases. If somebody has a sprain or a disc, normally they would have symptoms from anywhere from 2 weeks to 2 months, and then the symptoms would improve. Whereas with this type of pain, the pain will have been for at least 3 months. And it may wax and wane, but it will always be there. So these are, we're talking about if anybody has the typical symptoms of inflammatory back pain, if they have any sacroiliitis on any of the x-rays that are done, or they have HLA-B27 positive, this is sort of a time when the general practitioner, for example, would normally think about referring to a rheumatologist. So the other thing that's happened is that there are the occasional patients, particularly ones that have had something like reactive arthritis or psoriatic arthritis, who will mainly have peripheral arthritis. And this wasn't always very well captured in the past. So when they were doing this criteria, they also set one up for peripheral spondyloarthritis. So this is a patient who has mainly arthritis, enthesitis or dactylitis, plus these one or two of the others. So once again, they have to have at least one other feature, which includes uveitis, psoriasis, inflammatory bowel disease, HLA-B27 positive, or X-ray changes, whether it be X-ray or MRI, or they could have had 2 or more features. And we do use that as well. So depending on if the patient predominantly presents with axial or spinal involvement, so that can include the neck, the mid-back, or the low back, then you would use the criteria for axial SpA. If they mainly have peripheral symptoms, then you can use the peripheral SpA one. So these are just putting them together. Now, when this was first developed, this was mainly used as a classification for not so much for diagnosis, but using it for research. But they were trying to decide how sensitive and specific these criteria were. And as you can see on the top, when they look at about almost 700 patients who had had chronic back pain, and they tried to see how sensitive some of the criteria were, in terms of their sensitivity and specificity, these new criteria actually perform very well, over 80%. So they are really quite good for making a diagnosis. And so now, and this is the important thing, is that if they're used by rheumatologists in the context where these were developed, then they can be used for diagnosis. And one of the issues in really becomes access to medications. And in BC, we are fortunate that I'm one of 3 rheumatologists that work very closely with pharmacare to have access to biologics. And we have been able to convince pharmacare to be able to use these criteria in order to be able to diagnose patients and have access to biologics. So we do not require, or the patients do not have to have positive x-rays in order to be able to get the medication. That's not true all across Canada by any means, but in BC, we are able to do that. So this has been a really big development and has made a huge difference in terms of how early we can get drugs for patients. In terms of prevalence, and there's a lot of variability around the world, and as you can see, in the United States, it's estimated to be approximately 1 to 1.5%. The incidence of rheumatoid arthritis is probably about 2%, so it's almost, not quite as high as the prevalence of rheumatoid arthritis. Now, HLA-B27 occurs in about 8% of the U.S. population, and we can extrapolate this to Canada. So there will be a lot more patients who are HLA-B27 positive who do not have ankylosing spondylitis. So just the fact that the test is positive does not necessarily mean that you have the disease. And you can see it varies a lot. The Haida Indians actually have genetically a very high incidence of 50% will be HLA-B27 positive, with about 6% of them having the disease. And this is just variability. This is ankylosing spondylitis in the population on the left, and these are different countries around the world. In the middle is ankylosing spondylitis in patients who are HLA-B27 positive, and on the right is just SpA, so general SpA of all different kinds in the population. So you can see that there is quite a bit of variability depending where you are. So the other issue is if we now are saying that we can diagnose this disease early, so the patients have no x-ray changes, what happens to these patients over time? Do they all go on to develop ankylosing spondylitis? How rapidly? Is there variability? This is something that there's been a lot of interest in. So in terms of studies that have been done, it's really variable. And it looks as if in the first couple of years, somewhere around 10% of people will go from what's called non-radiographic to actually having changes on an x-ray. Within the next, sort of the first 10 years, it's anywhere between 20 and 45%. And after 10 years, it's approximately 40 to 60%. And again, a lot of variability. They're not great studies, but these are sort of the best data that we have. But there are some issues with this, which I'll try to describe. So basically, they tried to look at patients who had less than 3 years of symptom duration. Now, these studies are not wonderful studies, as I mentioned, but this is basically the best we've got at this point in time. And you can see there's a lot of variability, anywhere from 12 to 68%. So we don't really know exactly what's going to happen with people over this period of time, and that's been one of the difficulties in terms of trying to decide when you make a diagnosis. We do know that there are certain things that will predict progression from non-radiographic to true ankylosing spondylitis. And if you have already inflammation on your X-ray or MRI, obviously you're more likely. If your C-reactive protein is up, so you have evidence of inflammation. If you have pain in the buttock area, that's a predictor. If you have HLA-B27 positive, not everybody does, and men. And in the past, Barry and I will tell you that when we first started training, it was really felt that ankylosing spondylitis was mainly a male disease. It was not common in women, or it was not felt to be common in women. And one of the issues was because the symptoms were felt to be more in sort of the neck and mid-back area, not as sort of traditional as it were. Whereas there's been a lot of interest. Well, first of all, I'm just going to talk a little bit about the issue of progression. So people can have different rates of progression. And one of the issues is this was a very good study that was done looking at patients, and you can see that the long-term progression is all over the place. It's not a straight line. And so that's one of the problems. It's really, really variable, so it's difficult to predict. And this is the probability of progression over a 4-year period. Some people will progress very slowly, some people moderately, and some very fast. And it's sometimes difficult to predict. And as I mentioned, these are some of the things, including hip involvement. So people have hip involvement, they're much more likely. in the order of about 25 times more likely to progress. And neck involvement is also very important. Okay, so when you look at women, when they've looked at, in the last couple of years, there have been a lot of studies looking at what's called non-radiographic SpA. So these are patients who have not yet developed X-ray changes. And they found that women actually make up at least 50% of that cohort, which is very, very different from what used to be thought to be the case. And these are in all these different studies. So we're recognizing more and more that a lot of women have this disease, and it's probably just as common as it is in men. Whereas if you look at ankylosing spondylitis studies, this is the percentage of women that are traditionally in studies where the patients have been diagnosed as having ankylosing spondylitis on the basis of X-rays. So just to go back, this is patients that do not have X-ray changes yet. So this is about 50%. And then if you look at the studies with ankylosing spondylitis, it's like 25%. So there's a big discrepancy. And the percentage of female patients is really dependent on the year of diagnosis. And part of this is, again, because we're more and more aware of the fact that more women have this disease. And it's more one-to-one than it used to be. So it's an interesting, nobody's really sure exactly why this is true. I think a lot of it, again, was because a lot of physicians were just, and had it in their head that only men could get this disease, that it wasn't a disease that was common in women. And it may be that the women don't develop X-ray changes as much as men do. And some studies suggest that that may be the case. And looking at this, interestingly, they found that if you look at the age at diagnosis versus the age at disease onset, women had symptoms at the same time as men, but they were diagnosed quite a bit later. So I'm just going to look a little bit at, these are different groups, different studies, and just to show the fact that, in fact, when they look at the non-radiographic early disease, it's just as bad, essentially, from all points of view, as people that have X-ray changes. So even though they're early in their disease, they have every bit as much pain and limitation and difficulty with function and so on and so forth. So it is, even early, a very significant burden of disease for people. So as I said, we're really working hard with these new criteria to try to make it easier to diagnose people. And we're hoping that we're going to get better MRI access so that we'll be able to do MRIs earlier in people as well, which will give us a better idea of what the natural history is as well. So again, just to show that there's, in terms of the age, in terms of the number of women, in these two studies, it was approximately 60% in these early studies. Again, 75% of them were HLA-B27 positive, and about 30% of them did have the inflammatory markers in all of these different studies. They all had what we call BASDI, as a measure that we do to look at inflammation. They all had, again, significant changes. So it's this, in the last 2 years, there have been many, many studies that have said that the disease is often unrecognized for many years, but that the patients have every bit as much pain, disability, and trouble with function as the patients later on. So it's very important to recognize them early. All right, so I'm going to talk a little bit now about treatment. And obviously, we're treating the back pain as well as the peripheral arthritis, enthesitis, the eyes, the colitis, and the psoriasis. But one thing I just wanted to mention, and I'm not going to go into a lot of detail, but the other thing that's happened a lot in the last couple of years is that there's more and more recognition that cardiovascular disease, the risk of cardiovascular disease, is increased in people that have any form of inflammatory arthritis. It doesn't appear to be quite as high in ankylosing spondylitis as it is in rheumatoid arthritis or psoriatic arthritis, but it is significantly elevated, and it's related to the inflammation. So the more we can control the inflammation, the more we can prevent this from happening. Smoking, and there was Barry and I just came back from a meeting a couple of weeks ago, the big European rheumatology meeting, and there was a lot of information about smoking. Smoking does increase your risk of disease. It makes the disease worse, and you don't respond to medication nearly as well if you smoke. So smoking is a big risk factor. We know that it also obviously increases your risk of cardiovascular disease. So the last thing anyone with inflammatory arthritis should do is smoke. That's a really big no-no. And one of the things that we as rheumatologists are getting more and more proactive in trying to tell our patients in no uncertain terms that they should definitely not be smoking, because they're really putting themselves at a much higher risk. So this is the recommendations for treatment, and we know that, of course, that education is very important, exercise, and typically, as I was mentioning, people get better with activity. So we really push our patients very hard to exercise as much as they can, not necessarily jogging or something like that, but swimming is fantastic, bicycling, as much as they can do to be active. And we know that people lose mobility over time, 10, 15, 20 years, and lots of studies have shown that one of the best ways to prevent that is exercise, in particular what we call extension exercise, because that's the movement that tends to get lost first. So again, it's very important to do regular stretching as well as aerobic exercise. All right, so we're just going to talk about all the different forms of treatment that are available. So in terms, obviously, we're trying to decrease disease activity, decrease pain, morning stiffness and fatigue, all of which are very important for patients. We're also trying to improve mobility, as I was mentioning, and to improve productivity, so get people back to work, which is something which is obviously extremely important because it's a relatively young population at the beginning. And prevent damage, that's of course. So quality of life and socioeconomic status is very important. All right, so we're just talking about, we're not going to go through a lot of detail. I'm just going to try to go through some of the different forms of treatment. So what I'm going to talk about a little bit is physiotherapy. We know that that is very important. And there are lots of different, they've looked at individual home-based exercises, group exercises. They all work, but it's basically exercise and teaching people stretching and strengthening. And it does make a big difference in terms of their symptoms and slowing the progression of the disease. Anti-inflammatories. These, for many years, had been the cornerstone of treatment for ankylosing spondylitis before we had access to the newer biologic medications. And there had been a couple of studies in the past, one in particular, that had shown that there seemed to be less radiographic progression in the spine in people who were taking more continuous anti-inflammatories. It had never been clear. The study was a very small number of patients. People were not 100% sure if it was actually true or not. But again, in the last year or two, there have been several studies which have now shown pretty definitively that taking anti-inflammatories in a full anti-inflammatory dose on a regular basis definitely does seem to slow the progression of the disease. So I think that there's no question now. One of the issues is that a lot of the anti-inflammatories have other side effects, including stomach side effects and so on and so forth. So it's not always possible for patients to take them on a continuous basis. But theoretically speaking, people should be taking anti-inflammatories on a regular basis as much as reasonably possible, because they do seem to make a difference in terms of slowing the progression. Injections of, we don't usually use corticosteroids by mouth very often. Would only be very occasional in patients with ankylosing spondylitis. We do sometimes do injections in the sacroiliac joints, and they can be quite effective in terms of controlling the pain for a period of time. In terms of what we consider our traditional disease-modifying drugs that we use a lot for things like rheumatoid arthritis, these drugs have really not been shown to be effective for the spinal disease of ankylosing spondylitis. They sometimes work if you have peripheral arthritis mainly, but really are not very effective in the spine. And for that reason, we're not required to use these drugs in someone who is going on a biologic, as opposed to what we see with rheumatoid arthritis. So we're going to talk about the tumor necrosis factor inhibitors, which are these biologics that have now been available basically since about 2001 in Canada. We now have 4 of these drugs which are available for treating spondyloarthropathies. 3 of them, you've all heard of etanercept, adalimumab, and golimumab, are given by subcutaneous injection, and infliximab is given intravenously, and they all work. Basically, in terms of the arthritis, including the enthesitis and the dactylitis, as well as the spinal manifestations, they are all pretty much equally effective. There's not any significant difference between these 4 different drugs. And in terms of their long-term efficacy, they've been very similar. And they seem to be effective over a long period of time, so we don't really lose effectiveness, which is great. And there is data that if somebody has to switch from one to the other, it can still be very effective. So just going to talk a little bit about the non-radiographic, because again, this is what's been, so these, even in people that did not have any positive x-rays that were given these drugs, they were still very, very effective. So they, even early on, they can be really fantastic drugs and work extremely well in different patients. And this is for basically all of them. And there have been significant changes on the MRI as well. So this was the first. Just going to go back a little bit. The first one was with adalimumab, which is one of the drugs. The second is infliximab. Then again, this was with etanercept. And this is another one with adalimumab as well, where there was really very significant. And they found that patients that were of younger age who had elevated inflammatory markers were the most likely to have a really good response to the drugs. So again, the patients with less than 5 years of disease did extremely well as the ones that had abnormal CRPs. So they're good markers for that. And very significant changes on the MRI. One of the issues has been, and this has been something that has been, we've seen with the payers as well, is that it doesn't appear as if these drugs actually inhibit radiographic progression as opposed to the anti-inflammatories. So some of the payers have been saying, well, if we're really not changing the x-ray over time, are we really having an impact on the disease? And in terms of patient symptoms, in terms of function, getting back to work and everything else, we are. And there's been a lot of theories as to why they don't change radiographic progression. Is it possible to do that or not? One of the theories is that if you're getting rid of inflammation, it appears, as opposed to rheumatoid arthritis, that you, as a healing process, you may be actually forming bone in someone who's had underlying inflammation. So you get rid of the inflammation and then you form bone. So there's lots of different theories about this, but this is something which, and Dr. Maximovich has also done a lot of work in this, and essentially he feels, and there's more and more evidence to support this, that if you can treat people really early, before they have had a lot of damage, you might be able to prevent this progression to X-ray progression. So hopefully, if we can get access to patients earlier, we may be able to make a difference in terms of the radiographic progression. So that's what we're hoping for, so that there's a window of opportunity, and it's one of the reasons why there's such a focus on trying to treat people before they are radiographic, as it were, early on. All right, so basically that's some of the issues that we've been dealing with. And we've been working hard, as I said, and with PharmaCare. And we now, I think, have pretty good access in BC to TNFs, which is good.
Thank you very much, Dr. Flanagan. I just want to, I think you know this already, but we're not taking questions with each speaker sort of following them. If we do, we may never get to the end. So we're going to keep the speakers going, and you have yellow cards with you. And if you choose to write a question down, we'll collect those up and we'll deal with questions at the end. The next speaker is Dr. Kaler. Dr. Kaler is a rheumatologist in practice originally in Thunder Bay. Many years ago, 25 or so, came to BC, was the executive director, the medical director of the Arthritis Society for a number of years, has been in practice in Richmond for a number of years, and is a clinical professor emeritus in the faculty at UBC. And his topic is spondyloarthropathies, ankylosing spondylitis, cousins, and what makes this family tick. Excellent title.
Is this one better over here? Okay. So how many people with ankylosing spondylitis, new ankylosing spondylitis, do people think I saw in my office this week? 1, let's say 0, 1, 3, 5. 5, 3, Anybody say 3? 1? Okay, so three is right. 3 new patients in 1 week with previously undiagnosed spondylitis. So, granted, I'm a rheumatologist, so you expect to get a concentration, but it just shows how common this is. So, well, they were all basically certainly under 40, yeah. And I have to say, mostly guys this time. Though speaking of that with Kathy, I remember back in the 1970s, I saw a lady, and this is when I was in Thunder Bay, who I was convinced had spondylitis, but this was before HLA-B27. She didn't have any radiologic changes, and I followed this lady on for several years, and I treated her as spondylitis, but I had not one iota of evidence other than her clinical symptoms to make that diagnosis. So what we're going to do is cover basically classification. I'm going to go back actually to the more classical, if you like, classification, just because you'll often get this in a rheumatologist's office still. A bit about hypothesis of the pathogenesis of how the disease develops, the unifying features, which Dr. Flanagan's already covered, and I'm going to do it again because you have to keep hearing it, and features of some of those types of arthritis. So one of the hypotheses, and remember these are all just ideas people have very often, is that spondylitis is an enthesitis-driven disease. And Dr. Flanagan talked about an enthesitis. It's where a tendon inserts onto a bone. I'll come to that in a little more detail. And that there are genetic influences, of which HLA-B27 certainly seems to be the most important. Now, there's a thing called population attributable risk. And that basically, as I understand it, I should have gotten my colleague Charlie Goldsmith to make sure I'm right of my interpretation, is that if there were no HLA-B27 in the population, how much would the incidence of ankylosing spondylitis fall? And the estimate is about 90%. And you'll see that that's sort of borne out. There's another genetic thing called endoplasmic reticulum aminopeptidase. That provides a certain risk. There are other genetic features that provide certain risks, and you can see them all down here. And the whole influence of genetics on rheumatic diseases and other diseases is certainly burgeoning, but HLA-B27 was the one that really came to prominence early in the game. So fundamentally, the prevalence of spondylitis parallels that of HLA-B27. So as Dr. Flanagan said, 50% incidence in the HIDA and about 6% incidence of ankylosing spondylitis. And that's a British Columbia story. Our colleague, now deceased, Phil Gofton and Harold Robinson did some of those seminal studies on that. Huey Smythe in Toronto was involved in those. And so the HIDA and other groups with high incidence of B27 have a high incidence of spondylitis. On the other hand, when HLA-B27 is largely absent in the population, so is ankylosing spondylitis. So there are a bunch of groups where that's been identified. And so again here, what's the risk that B27 contributes? It estimates, again, all these studies vary because of different populations, but anywhere from 16 to 50% of the genetic risk. But as you see, only about 5% of B27 positive people develop spondylitis. So there's obviously other things going on, and most of those we don't really understand. So now we get into stuff I don't understand at all either. But here's a sort of a cartoon rendition of a HLA-B27 molecule, and there's something in here called the peptide binding clef. And the idea is that there's some sort of inciting antigen, some sort of usually protein particle that deposits in here and sets up an inflammatory response. But the thing is, now it gets complicated. There are 48 different subtypes of HLA-B27. And some of them aren't associated with ankylosing spondylitis. So what's going on? So there are a bunch of different subtypes that are very commonly associated, B2705, B2704, more often in China and Chinese and Japanese. And I would point out in Guangzhou, there's one of the professors there at the First Affiliate Hospital has a very high profile in her studies in ankylosing spondylitis, B2702. But here's a couple where there's very weak associations. And what's the difference? It's one peptide molecule. One little molecule that makes this huge difference. You always wonder why we're all sitting here and walking around. We're so complex. And some minor things make such huge difference. The fact that we're all actually sitting here is always quite an amazing biologic feat. So what the HLA-B proteins do is they present peptides and they activate certain lymphocytes called CD8 plus T lymphocytes. And what's happening here is that usually these are tolerant to these peptides that are presented, and they can even be they can also become tolerant to other peptides that from bacteria. But there is a theory, and I'm sure any of you who've been reading about spondylitis would have come across this, that certain microbial peptides are very similar to our own peptides, and so they'll lead to getting into that little cleft in the HLA B27 molecule and setting up an autoimmune response. And that may be, we don't know. It's a nice hypothesis, but nobody's ever been able to identify a specific bacteria or virus that's consistently associated with this. So is this right? Possibly, but we don't know. Here's some even more complicated stuff. So the spondylitis patients have an increase in certain of these immune response cells, and that there's something in how B27 molecules interact with these cells that lead to them becoming more active. Maybe. Here's one that's even more interesting, that in the endoplasmic reticulum, the immature B27 molecules accumulate and they overload the protein response, and so they get an increased inflammatory response. So what's that tell you? It tells you and tells me we really don't know. There's lots of interesting hypotheses. Why do we even bother? What does it matter? Well, it matters because one of these days we'll have a better idea of which one of these, or perhaps one totally unrelated, that is true. And then we'll be able to intervene at a much more fundamental level in managing the spondyloarthropathies. And that will be a significant thing. It'll be way back to the level of germ theory. And when we discovered bacteria, that was the first step to antibiotics. But it took a long time to discover bacteria. So there were lots of different ideas about infectious diseases, miasmas from the swamp, different colored humors circulating in your body. And I tell the medical students, and then there was that crazy guy who said there were these little particles you couldn't even see that caused the disease, and everybody thought he was really crazy. So this is why we have basic research. This is why you bark up a lot of trees, but very few of them have the cat in it. And but one of these times, you're going to bark up a tree, and the cat's going to be there, and we're going to make substantial advances. So don't underestimate the importance of basic research. So as Dr. Flanagan has already covered, there's subgroups here, ankylosing spondylitis being the classic, psoriatic arthritis, arthritis associated with inflammatory bowel disease, reactive arthritis. One I'm not going to cover, enthesitis-related arthropathy of childhood, which was, again, one of those things had some of its original description done here in Vancouver with Dr. Ross Petty and the pediatric group here, and in undifferentiated spondyloarthropathy. And there are some unifying factors here. The genetics, of course, there's really a strong familial aggregation. So if you have an identical twin and your identical twin develops a spondyloarthropathy, you better duck. Because you've got a high probability that's going to happen to you. Not so much, I tell people that, if Dad has ankylosing spondylitis and he's HLA-B27 positive and you're HLA-B27 positive, you still only have about a 20% risk. So there's that other 80% that comes into play. And a lot of that 80% obviously is something to do with being an identical twin. And B27 association isn't evenly distributed. So in ankylosing spondylitis, it's very high. In reactive arthritis, pretty high still, 60 to 70%. Psoriatic arthritis, much less so. And ethnically matched controls, even less so. So if you have two people from a same ethnic group, B27 positive, but still the concordance with one of them getting spondylitis and the other not is pretty low. And then, of course, the clinical things, the inflammation of the spine, sacroiliac joints, the entheses, and I'm going to come to that still, and peripheral joints in these other groups of diseases, but certainly sometimes in ankylosing spondylitis too, and dactylitis. So, finally, the enthesis. It's basically, as I said, it's where the tendons, ligaments, and joint capsule, which are really part of your ligaments, insert onto the bone. And T cells infiltrate here. Why do they infiltrate there? We don't know. That's such a, you'd say, well, why not? Why don't you know? And it's such a fundamental question. It would be lovely to know, and we don't know. But basically then inflammation sets up, and you can certainly get spurs. Those spurs are often overrated in radiologic interpretation, and certainly at the Achilles tendon and the plantar fascia, as Dr. Flanagan said, are classic places where they do occur. Dactylitis, the sausage digit, is not, although we think of it as sort of in a way arthritis, it really isn't. It's enthesitis, often associated with deformed nails, onychodystrophy, with tendinitis, more flexor tendons, the ones that do this, not the ones that do that, and periostitis, which is just inflammation of there's a tissue lining along our bones that surrounds our bones called the periosteum, and that can become inflamed, and you can actually, it certainly can cause pain, and you can sometimes see that on X-ray as well, as sort of a fluffy appearance. And the medications, again, NSAIDs are non-steroidal anti-inflammatories, are the classic drugs. Indomethacin was the one everybody thought of, and years ago phenylbutazone, but it has occasionally very nasty side effects. And generally we thought it not to affect disease progression, but as Dr. Flanagan has said, there's been some recent data to suggest that may not be the case. Certainly what I tell patients is, I'm not so uptight about you taking your medication, although I may change that tune if I get increasingly impressed by the studies. But if you come in and say to me, I wasn't able to do my exercises because I hurt too much, I'm going to give you crap. Because the one thing that really we've had long-standing data for is a structured exercise program improving or maintaining range of movement. So that's, to my mind, one of the most critical interventions we have. And the biggest thing is to get people to do them. And people lie about their exercise. How many have lied about their exercises? Yes. So I get very pointed about, oh, you're doing your exercise. How often are you doing them? And it's amazing how uncomfortable people don't really like to lie. They like to hedge the truth. So, but it is, and the NSAIDs, though, do work certainly for pain and in both the peripheral joints and the spine. Cortisone, again, intra-articular, although we also would use it in peripheral joints for injections, but we don't like to use it for chronic use. Straight pain pills or analgesics can certainly be helpful, but we do like to avoid the opiates, things like morphine, hydromorphone, hydrocodone, and those family of drugs, because there is a potential for dependence there. It's not a huge thing, and we probably are a little hysterical about it sometimes, but we do have to be sensible about it, both as patients and physicians. And then, of course, the slow-acting drugs, particularly sulfasalazine and methotrexate, they aren't effective, though, for axial, for spine involvement, the biologics. And you can see there's some differential efficacy in those, and we don't know why that is, but it's interesting that in different ones of the spondyloarthropathies, they'll be more effective or less. But as Dr. Flanagan said, they're wonderful drugs. They really are great. First time I went to an evening on this new agent at that point, infliximab, or Remicade, and I came out and I said, I've never seen a bunch of jaded old rheumatologists so excited about a new treatment. It's really been revolutionary. So, psoriatic arthritis, very common. The arthritis may precede the psoriasis may precede the arthritis, and it's more often peripheral arthritis. There are different patterns that I'll go through and show you. DIP, distal interphalangeal, joint predominant, like rheumatoid arthritis, spondylitis predominant, asymmetric, very damaging arthritis, and certainly our standard treatments that we often use in rheumatoid disease are often effective here for the peripheral, and some of our treatments work for both skin and joints, although not always. So here's this asymmetric where they get the wrists, the knuckles, the knee, balls of the feet. They get this dactylitis and the nail involvement. Of course, that's quite classic for psoriatic arthritis, although we do see it in other forms of spondyloarthropathy. You get these distal interphalangeal joints, the joints at the ends of your fingers. And again, you can see the nail involvement. Arthritis mutilans, this is character, and people, certainly our trainees we tend to tell them that this is classic for psoriatic arthritis. It's very severe, damaging arthritis, although you can develop it probably statistically more commonly in rheumatoid disease, or at least in numbers. But you can see how much damage occurs both on the actual hands and looking at the x-rays. And you see this sort of, again, very classic for psoriatic arthritis, where you get this penicillin cup where there's so much damage to the bone, it looks like somebody stuck it in a pencil sharpener and whittled it down. And you can see here just a little bit with this periostitis I talked about, the sort of fluffy appearance around the side of the bone. So those are the sort of changes. None of them are characteristic or limited to psoriatic arthritis, but they're often characteristic. Now, I show you this picture. This is a picture, the series of pictures were taken by my old professor, Metro Grislow in Toronto, and it's been used in probably every rheumatology textbook in the world to show the progression of ankylosing spondylitis. What happened here, do you think? This is 1972, this is 1973. Yep, exactly, he had surgery. This chap was mustered out of the Canadian Army, and this was a cohort at Sunnybrook Hospital in Toronto, and then followed over the years, actually by Hugh Little, who you mentioned. And so he had this great series of progression. Just about here, when I was finishing my training in Toronto, he was presented at rounds having had just developed psoriasis. So for all these years, and still in all these textbooks, this picture is presented as classic ankylosing spondylitis. In fact, he had psoriatic spondylitis. So Mother Nature loves to catch us. Again, I tell the medical students, Mother Nature loves to beguile us with coincidences. Reactive arthritis used to be called Reiter syndrome until that became politically incorrect. But there's a tetrad of arthritis, conjunctivitis, whoops, I left an N out there, urethritis. Amazing how often you find a typo the fourth time into the talk. and dermatitis, and it followed soon after genital urinary or gastrointestinal infections. By and large, there have been attempts. You really have not identified organisms in the joint, certainly not viable organisms. The usual course is benign and transient over months. Having said that, one of my patients came in. His daughter, working with Canada Meat Inspection, was exposed to a particular organism, developed reactive arthritis. She's on large doses of prednisone and a biologic from one of our colleagues in Saskatchewan. So usually benign, not always. And this is a funny disease in the literature because the literature is filled with reports from tertiary medical centers, and they say it's always a bad disease. Practically, Dennis Ford, who was a world authority on infection and arthritis in Vancouver, pointed out that that's the problem. It's in tertiary centers, and everybody who gets better doesn't go to tertiary centers, and so you get this funny biased literature. So if you have reactive arthritis and you go to the literature, it'll scare the crap out of you. But that's not the usual course. And the treatments are as I outlined here, except that there is a bit of data that says if you identify the inciting organism, which could be something like salmonella, if you give a good prolonged treatment for that, it may shorten the course of the disease. And again, you can just see the various places in the body where where reactive arthritis can evolve. The arthritis of inflammatory bowel disease, again, one of these things that may flare with the flare of the bowel disease, or the joint activity may be quite independent of what's happening in the bowel. So there's no necessarily correlation, especially in the axial involvement. There may simply be something like asymptomatic sacroiliitis. What you have to watch here is that non-steroidal anti-inflammatories tend to aggravate inflammatory bowel disease. So you have to be more focused in how you treat it. And again, there's this potential differential in biologics and how effective they are. And then finally, the undifferentiated spondyloarthropathy, which is the one that makes us scratch our head, which the Biologics Committee has been very helpful in letting us as rheumatologists be more interventive in this group of patients who they have some of the features, but not all of them. You can't make a classic diagnosis. You can divide it up as has already been done into peripheral or axial, but they're the folks we'd really like to get at first and early, because it may be that that's where we can actually make even a bigger difference, as is the case in rheumatoid arthritis. So what we've done very quickly, we've looked over the classification, some of the hypotheses about pathogenesis, and if any one of you in the audience truly understand this, come up and explain it to me afterwards. Some of the unifying features and some of the differentiating features. And it's a complicated but important disease, and we've evolved a long time. Remember back about 1930, ankylosing spondylitis was called rheumatoid spondylitis. We thought it was part of rheumatoid arthritis. So things have evolved, certainly in how we understand. The more we understand and subdivide, the more often we learn more about these diseases. And I think this is going to progress over the next 2 or 3 decades a lot faster. Thank you.
Well, thank you for having me, and good morning to everyone. As Bruce indicated, my name is Don Bindon, and I have AS, and I feel pretty good this morning. Just to give you an idea about a background, you remember Dr. Flanagan talked about all the kind of things that can happen to people who have AS and what they generally look for in AS. You just have to listen to me for a little while, and you'll get an idea about how it is they knew to have those things up there on the board about what it is you look for when you think somebody has AS, and what it is they think you have when they don't know that you have AS, when you're not speaking to the right people. So one of the things I want to talk to you is that I developed AS, my first AS symptoms in 1984. I was 15 years into a career in the mounted police at that time, and I presented, there's a good word, I actually ended up finding out that I wasn't feeling very well because a couple of things started to happen to me. One is walking. I got a driving pain in the right buttock one time, and it would happen to me every once in a while. And then it would go away, and it would be fine, but I was getting stiff. And I wasn't just getting a little bit stiff, I was getting seriously stiff. I would wake up in the middle of the night many times, and by the time the morning rolled around, I would actually roll out of bed onto my hands and knees beside the bed. I would reach up to the dresser. Fortunately, the dresser on that side was Amy's dresser, my wife's dresser, so I could get my hands up to there. And I would pick myself up like this, and I would be standing about to this height. And then I would start wandering around the apartment, and after about 30 minutes and a hot shower and 1,000 milligrams of aspirin, I would get myself into a rather somewhat erect state and could wander about after that. And I would be fine for a good portion of the day. And the more that I exercised and the more that I worked, the better off I felt. And every time I stopped doing things, I would start to feel worse. So I found out at work, for instance, people at work would realize that in the middle of a shift sometime, I would actually do all my reports standing up at a counter rather than sitting at a desk. Not only that, I'd had to get out of a police car every once in a while and wander around the police car a few times in order to be able to sit back in the seat afterwards for that as well. And it didn't get any better for a very long time. But I went to my doctor. And my doctor then said, well, we should have you checked out. And I went to some pretty good doctors and some specialists, and they figured out that one of my legs was 1 centimeter shorter than the other. I was horrified. Well, it turns out that most of us have one leg 1 centimeter shorter than another, and so they decided they would build up my shoes. So I took all the shoes I owned, went down to my local shoe repair shop, and we're inserting centimeter portions in right sides of all my shoes. I can tell you that if you have that done, they need to do it perfectly because it really doesn't help a lot of things. And in fact, it made my situation considerably worse than it was before. But then I got a little bit lucky. I got a little bit lucky because Amy got tired of me crawling out of bed and standing up the way I was and said, you know what you should do? You should go see a chiropractor. Horror, I know. Chiropractor, so I went to a chiropractor, and I got lucky. I actually ended up at a chiropractor who knew about AS. And he pummeled around on me a few times and turned me this way and turned me that way, and then came to a conclusion after a couple of visits. He said, you know what, I'm not helping you at all. He said, but I got an idea. He said, you really should go to your doctor and have your doctor send you to a rheumatologist and have them do a B27 test on you, which I had absolutely no idea what they were talking about or what he was talking about, but I did as I was told, and then I got lucky a second time because my doctor sent me to Dr. Alice Klinkoff at Mary Pack Arthritis Center. And to this day, Dr. Klinkoff is on my A list for Christmas cards. She is one of my favorite women by far. And I sat down and I said, I've been told to come and have this test done and stuff. And she said, okay, tell me about your life. What happens in the morning? What do you do? I said, I have a terrible time. I feel much better when I'm exercising. A hot shower is terrific. 1,000 milligrams of aspirin does really good things for me. And she said, I don't need to test you for anything. I know what you have. And then she just strung off a line of words in some language that I've never heard of before. And I thought, well, this can't be good. No one should have a disease with that many letters in it if you're actually doing all right. And as it turned out, you know what? There's a lot of things a lot worse in life than AS. A lot worse than AS. And I had the standard kind of start out in my treatment. I ended up with non-steroidal anti-inflammatories, and they worked like a charm. My starting out with them was perfect. They helped me out. They made everything work good. Unfortunately, they made my kidneys work worse. And if anybody understands about kidney stuff progression, and maybe some of you in the room have had that, I was starting to get lab tests back, and when it peaked at about halfway towards dialysis, Dr. Klinkoff said, enough of this. I'm not sure that I should continue to treat you in this manner and the possibility is you're going to end up with massive kidney disease instead of AS. And as a result, I came off of my NSAIDs. And my disease got a good hold for a while, a few years there. By the way, I had been 5 years. 84, I got to see Dr. Klinkoff in 1989, 5 years after. At that time, by the way, I think that was quite normal. I don't think that there was an awful lot of people getting diagnosed and finding themselves into the office of a very good rheumatologist anything less than about 5 years after they started the symptoms for AS, and I was no different. Those worked good. I came off of them, and then they came up with another non-steroidal. I think they were called COX-2 inhibitors or something. They would only sell them in the United States. So I would get a prescription, go down to Bellingham, paid full price, I might add, at the pharmacy in Bellingham, and I had those for a little while, but my numbers started to creep back up on my kidneys again, and so off of them. But guess how lucky your life can be, guys? I was one of the first people to end up on biologics. I started taking infliximab, Remicade. Thank you. I didn't pronounce my own drug. Remicade, and I think last count, I have had about almost 70, 65, 68 or 70 treatments. I get it every 8 weeks. I'm one of the more fortunate people. I don't have to have it as often as some do. And I have about the lowest dose, one of the lowest doses, and it works pretty good for me. So I'm now somewhere along the line of over 10 years of taking that drug. Nice thing also, I had insurance because it wasn't cheap in the beginning, and that insurance helped a great deal. So there's a lot of good things that have happened. I want to tell you about some of the other stuff that worked for me. I exercise. I play hockey. Don't tell Alice. Well, actually, she knows. It is not her favorite exercise for AS patient. Right? I can tell you that if you have AS and somebody 22 years old that is 6'2" and weighs 250 pounds runs over you when you are 5'5" and about 150 pounds and you have AS, it hurts. And that happens. So whenever I get knocked down at hockey, it hurts, but I don't care. I get back up, I wander over to the bench, I get a certain amount of sympathy from a bunch of other people around me for a little while. I sit there for a little while, move my head. Well, my head doesn't move very much, but back and forth, and I feel a little bit better, and I get back on the ice again. And I ride my bike, and I do other things as well, because AS is not going to get me down in any significant way. There are a lot worse diseases to have than ankylosing spondylitis. I do some other things. I have some of my other exercises. I, like the rest of you in the room, have never lied to my rheumatologist about my exercise regimen. I love those exercises that they make you do, right? I shall tell you, I cheat. Have cheated, did cheat from the beginning, right? There was something about the regimented exercises that they were the best ones. Why would that be? I mean, we could disco or something, and I figured that might be a little better one, right? There's a certain amount of effort needed to get up from the couch and go to the refrigerator and then back to the couch. I thought they would qualify, but apparently they don't. I would encourage anyone who gets told to do their exercises, do not follow my example about your exercises. I know some people who have taken their exercises and done very well with them, and guess what? They're a lot more mobile than I am today as a result of doing them. So I am confessing to not doing my exercises particularly well, and as a result, I'm probably not as good as I could have been, even though I have had the benefit of the best of drugs when it comes to this particular disease. I have to give you an idea about a couple of things. I don't smoke, by the way, so therefore, I highly recommend that you don't smoke. One of the things is I have found out, though, a little bit of wine has absolutely nothing about your AS, right? And it works just as well with red, white, or rosé. So, in case you were wondering, right? Don't smoke, but wine I think you can have. I think there's some other things you may want to know about me, that my family. I have a brother with AS. He is younger than me, and he's really the only one in our family that I can say has all of the classic symptoms of AS. His are pretty close to what mine were. My sister, who is a little bit older than me, her doctor thinks that she has a mild case of AS. Came very late in diagnosis for her. She's 70 years old, and they figured out maybe when she was already, and somebody spoke about nearly 50 years old, I think they kind of thought that. They believed before her death that my mother may have had some AS as well. Our children, my daughter is HLB27 negative, but she has arthritis, but she hasn't got this one. Our son does not have any symptoms at all. He's coming up 47 years old, so he's kind of creeping up on the age where you might actually see it. So it does present itself in families a little bit, but in many cases, until I got diagnosed, none of my siblings or anybody else figured out what they had. It was only after I had gotten lucky that started talking to them about what I had and what my symptoms were that my siblings began to think, and somebody said to my brother, you'd better go see a rheumatologist because you have exactly what Don has, or at least you present exactly the same way that he does. One of the things I would like to say, though, it's been very fortunate for me in order to get the kind of treatment that I have. I am very glad that the current system, and Dr. Flanagan spoke a little while ago about being able to get people onto certain medications without going through this long, convoluted system of trying this drug and trying the other drug and doing a bunch of other things. I'm very much in favor of that happening now because I think for some people, a shortcut to the drugs that work may very well be the right answer in the direction that we're going. It is unfortunate in some ways, but understandable that these are very expensive drugs. Right? Having AS and getting a biologic ain't cheap, but it does work. I've been lucky enough to have good insurance coverage, so that's been helpful to me, and I'm very pleased in the last little while that the provincial government here has actually added it to the list so that people can get assistance in doing it here as well. So for those of you who have AS in the audience or have loved ones who have AS, the thing that I'm here to tell you is that at 65 years old, you can still be okay with this drug. However, if I was to actually do a couple of things, you might notice some of the stuff about it. My head doesn't move real good in any direction, but I'm upright. I get up every day. I don't hurt like I used to. I still get a little stiff at sometimes in doing some things, but I could be an awful lot worse off. So I say this to you. If you want to actually have the best possible results about the possibility of AS, the very best thing you can do is have a really good friend who's a rheumatologist. Because most of the doctors today, I'm hopeful they're all going to get better at it, but most of the doctors today, until you get to a rheumatologist, mostly you're going to flounder around a little bit, I think, in some of the directions, although I think maybe they're going to be better at it in the next little while. So I wish you all very good luck and the stuff, and thank you for putting up with me for a few minutes. And I'm in the way towards coffee, but I have moved along on time as well. So enjoy the rest of your day, everyone.
Ladies and gentlemen, it's about time we got going. We got going again. So feel free to continue your refreshments. But in order to keep us on track and have an adequate amount of time for questions at the end, I think we should continue. And so our next topic is Dr. Briar Sexton, who's an ophthalmologist in Vancouver. She shares an office with Dr. Kevin Wade in Vancouver. She's a clinical associate professor in the Division of Ophthalmology at UBC. And as you've already heard this morning, that eye-related disease in association with the spondyloarthropathies are a common happening. I'm sure many people in the group here have had such difficulties. So I'm delighted that she's here to share her expertise with us. So Dr. Briar Sexton.
Good morning. So here today to talk to you about iritis and how it fits into the broader picture of spondyloarthropathy. Can I see how many people in the room have had an episode of iritis at some point? Yeah, so that's pretty typical. And What I'm going to do is I'm going to start with an overview of the anatomy of the eye. I'm going to go through the symptoms of uveitis, what would make you suspicious that you have it. What does your doctor look for in the eye? I'll show you some photos. How to treat uveitis, some of the complications of treatment, and what happens if the treatment doesn't work. And what I'll typically see in my practice is two groups of people. Either I'll have people referred to me because they have iritis, and sometimes in that case, I'm doing their HLA-B27 blood work, and I'm, talking to them about low back pain and about psoriasis and other things, and trying to triage them to get referred to get looked after. Other times I'll have a patient who comes in with one of the spondyloarthropathies because they're on a medication where I'm screening them in the eye and letting them know that, hey, I'd be a great point of contact if something were to change for you going forward. So anatomy of the eye, I'm going to just walk you through it. So the term uveitis is a very broad term. It means an inflammation of anywhere from the iris, the ciliary body, or the choroid. So when we look at the eye, the iris is the colored part, the part that you see when you look at somebody that makes you say, okay, they've got blue eyes or brown eyes. But then there's this clear front window, the cornea. And when we talk about iritis, we're talking about an inflammation of the iris. And what I see when I look in the eye is white blood cells in this space between the cornea and the iris. So the iris blood vessels become inflamed and they start to leak white blood cells. And that's what I'm actually seeing when I look in. For those of you who have iritis, you may, when you go to your doctor, ask, well, how bad is it this time? And they'll kind of talk about a grading system between 1 and 4. And that sort of refers to how many cells we're seeing in the light of our slit lamp. And I'll show you guys pictures of that going forward. With HLA-B27 related iritis, usually you are just confined to this front chamber. But sometimes, if the inflammation is acute enough, some of the cells leak back into the vitreous. And very, very seldom with the HLA-B27, you can even get swelling back in the retina, the lining of the back of the eye that works like the film in a camera. Okay. So symptoms of uveitis or iritis: redness, pain, light sensitivity, and blurred vision. And so that light sensitivity is often the real kind of indicator for family doctors or for you as a person, or for me when I get that phone call that maybe this isn't pink eye, maybe there's something else going on. That intense light sensitivity is often one of the real tip-offs. Blurred vision, because you've got these white blood cells circulating in the anterior chamber, so you're looking through a snowstorm, so your vision's blurred. The pain goes with the inflammation, and the redness, they'll often talk about something called ciliary flush, where you're more red close to the edge of the cornea than further out around the white of the eye. So I'm showing you this picture because one of these patients has got pink eye, and the other one's got an inflammatory spondyloarthropathy related iritis. Can you tell which one is which? Does anybody want to guess? Exactly. So if you can't guess, I can't guess, your GP can't guess, your optometrist can't guess, your walk-in clinic doctor can't guess, you absolutely have got to get to see an ophthalmologist. Because I have one of these in my office. And that's what I'll say to my patients, is you don't have this at home, and I don't have this when I'm talking to you on the phone. You've got to come in and you've got to let me look, because there's no way you're going to be able to describe it to me convincingly. Your GP doesn't have this equipment, even if they're awesome, even if you've known them for 20 years, even if they're really, really bright. Having said all that, I have once diagnosed iritis without my slit lamp. I was on my second date with my husband, and he showed up, and we went out to a pub to watch the hockey game, and I noticed his eye was red, but it was pretty dark. And then as soon as we walked out into the foyer, into the bright light, he couldn't keep his eye open. What's going on? Can you look at me? And I look, and his two pupils are two different sizes, and one eye's bright red. My goodness, you've got iritis. And he did. And it was his first episode, and he married me. So, yeah, exactly. I didn't give it to him. You can't do that. But anyway, apart from that, really you do need one of these machines, this slit lamp, to have a good look in the eye, to really know what's going on. The other reason that it's really helpful is for any of you who've had this thing where, when you have iritis, it's episodic, meaning it comes, stays around for a few weeks, we treat it, it goes away, and then it comes back almost inevitably on a Friday or a Saturday when you can't get in to see your doctor. And so you're at home and you're going, what do I do? What do I do? And when I get the benefit of looking in, I can say, hey, we've caught this really early, we're going to dose it this way. Hey, we didn't catch this very fast, or it's really, really aggressive this time, we're going to do it that way. And that really helps me to figure out how much medication you need, how long you need the medication, how quickly I can start to taper it. If I don't see it for 2 weeks after it starts, I'm in a totally different picture. So that's why you do get us nitpicking, come in as soon as it happens. And I think for patients it's tough because it's the same old thing. They know what it is, and they don't really want to go and sit in the waiting room for a couple of hours. But that's some of the rationale for why we like to see you. So this is Know Your O's. This is my public service announcement here. So, you know, these three look exactly identical, but they're very different in their scope. And in province of BC in particular, it's very difficult because you have opticians who can now dispense eyeglasses without the benefit of actually doing an eye exam, and that's unique in North America. Then you have optometrists who do very good screening eye examinations for eye health and who are excellent at distributing your glasses prescriptions. They now, and this is only 2 provinces in Canada, can actually dispense treatment for iritis. They can manage it. And that's been difficult because while they can treat it, they can't look into the underlying causes. They can't order your blood work. They can't order the chest x-rays. They can't order an x-ray of your lower back to look for ankylosing spondylitis. And often, while they're comfortable treating it in the short term, they haven't got a lot of training on what happens if something goes wrong, what if it gets complicated. And so I'll often end up getting a patient who's been really in good faith being treated by their optometrist, suddenly sent along to me, and they say, well, why do I have to see you now? I already have an eye doctor. I say, well, actually, you have an optometrist. They're not a medical doctor. You know, they're very good at what they're good at, but they don't have the same training as an ophthalmologist. So, and they call themselves doctor, and it's confusing. So you need to make sure if you do have iritis or you think you have iritis that you're with a medical eye doctor when you're getting looked at and getting treated. Okay, and so what does your doctor look for in your eye? These are some great photos, but you know, I think when you don't have the benefit of being able to see things up closer with the slit lamp, you kind of wonder what's going on. So this picture over here is a pretty aggressive uveitis. Can you see that white line across the bottom? There are so many white blood cells circulating in that eye that they're actually piled up on the bottom. That's what we call a hypopyon. And that will often be the point that somebody gets to me with a B27 iritis because, you know, it's a young guy, he's 25, 27 years old, maybe he's got small kids, and he's tough. And he thinks he has pink eye, and he's not going to the hospital or to the doctor until it gets to this point. So when you see it like this, and it's really severe, you're going to end up putting this person on very high-dose medication, possibly oral, possibly even doing an injection into the eye to try and calm it down. So the earlier we catch it, the less aggressive the treatment has to be. So that's important to know. Here what I'm looking at, this is the cornea, the clear front window of the eye, except in this case it's not so clear. You can see the pupil behind it and the brown iris. And what we're seeing here is aggregate clumps of white blood cells that are on the back of the cornea. So here they're clumped down, they're at the bottom. Here they're actually sticking to the back of the cornea. And that will melt away with proper treatment. Vision's going to go back to normal, most likely. But again, it's an indicator that this is severe inflammation that's happening. Can you see that this pupil is not round? Okay. That's what we call a synechia eye. And what happens is when the iris is inflamed like that, it's very, very sticky. Extremely rarely, one of the pieces of the iris can stick to the cornea, but quite commonly, it'll stick down on the lens, okay? That's your clear lens inside the eye that becomes a cataract as you get older. And where it's sticking down in this person, you can appreciate the pupil's still quite big, right? This person can see out, I can see in. My worst nightmare is my iritis patients where I end up with it stuck down all around a little spot right in the center. So you've got, at that point, no real window for someone to see out and no real window for me to see in and see what's happening in the back of the eye. And those patients sometimes need to go on to have surgery, to have that iris surgically stretched so that we recreate the opening for them. And that's a bad outcome. unquestionably, that's something that we really try and avoid. And I'm going to talk to you next about what are the medications, how do we try and solve these problems, and what's the rationale for using them. Here's our worst nightmare, and I see it very, very, very seldom in my spondyloarthropathy patients. It's extremely low incidence, much more common in other forms of iritis. But this person, this is the retina, the tissue paper lining in the back of the eye that acts like the film in the camera. If something goes wrong with your retina, there's really not anything we can do to fix it. People say, well, what about glasses? You know, why can't I just get a better pair? Well, you've got to figure that if you had the most expensive lens in the world on your Nikon camera, and I pulled the film out of the back, you're not going to get a good picture. And that's what's going on when you get retinal damage. And so this person's got this yellow and white matter in the very, very center of their vision. It's called cystoid macular edema. It's an inflammatory response. It can be seen in iritis, although very rarely in my spondyloarthropathies. But once we start to see that, that's when I have to tell somebody that there's a reasonable chance that they're not going to get all of their vision back once this episode is over. And so, again, you know, for a lot of people, they've got kind of chronic low-grade inflammation, and they come in and they say, Dr. Sexton, I've been on the drops forever, and I don't feel like they're helping. And, you know, why don't you, it's not even bothering me that much. Like, why don't we just let this go? Well, the reason we don't let it go is we know that the longer that untreated inflammation exists in the eye, the more chance that we're going to start to get into complications like this. So how to treat uveitis? I'm not advertising for the drug companies, but this is pretty standard treatment, okay? And I will say, so this Predforte, that's a steroid drop. It's a topical form of prednisone, and that's our mainstay for most people for you treating uveitis. There is another steroid that's come on the market in Canada called Lotemax that we'll use sometimes because it's got a lower side effect profile, and I'll talk about the side effects in a minute. But for severe problems, for somebody whose eye looks like this, or like this, or like this, or like this, Predforte is still the #1 treatment. And the reason that I'm emphasizing that is there is a generic form, and it doesn't work as well. The one that I'm showing you here is milled 30 times in its suspension, so the granules are really tiny. In the generic, they mill it 3 times. So you're trying to dissolve huge granules in a suspension, and you just don't get the same effective dose. Health Canada says, well, the same amount of drug is in the bottle, but it's not the same amount of drug that goes to your eye. It gets complicated a little bit more in British Columbia because even though I write down as your physician, I would really like for you to have Predforte. I want you to have the best thing possible. Your pharmacist can substitute for the generic without my authorization, and until January 1st, 2013, they're then financially compensated by the generic company for the substitution. And so it's worth knowing about if you're somebody who has iritis, because I'll have somebody come in and I'll say, geez, you're not responding the way that you normally do. Can I see your medication? And oftentimes they'll pull out and they haven't got the one that I've written for. They've got the generic. And I do a lot of education with my patients, but still the drug companies will sometimes substitute. I've even seen them come in with something that says Predforte on the sticker around the bottle, but when I peel it off, I've got the generic underneath. Maxidex is an ointment that's sometimes used in severe uveitis for nighttime treatment because the drug dosing lasts about 3 or 4 hours. So it keeps you from having to get up overnight to put in your Predforte drops every hour. Sometimes in less severe uveitis, it's not used. Cyclogel, anything with a red top on it in the ophthalmology world dilates the pupil. And so we use Cyclogel, and patients hate it, but we use it for 3 reasons, and I always try and go over it with them so they know why I'm doing it to them. Number 1, iritis. Your iris is a muscle. Your muscle is spasming. Your muscle is going to spasm when it sees light, and that's what's causing you a lot of the light sensitivity, photophobia, pain that you're having. If I can stop the muscle from spasming by dilating the pupil and keeping the iris nice and big and frozen, I can take away a lot of your pain. Why don't I use something that makes the pupil smaller? Because if we go back and we look at that picture of this guy with his synechia eye, that's where I want it to happen if it's going to happen. If I paralyze the iris as being small, then that sticking would happen right in the center of vision. Typically, though, if we do intervene early and we use those dilating drops, we don't see sticking at all. So that's the other reason that I'll use it when things are really acute. Again, patients don't like it because it really blurs their near vision. It makes reading and computer work quite difficult. So we use it only for as long as we need to, but we use it for very good reason. Complications of treatment. So again, people are bright and they're educated about their own health care in this day and age. And it seems intuitive that, geez, I know exactly what's going to happen when I go see Dr. Sexton. She's going to put me on the drops every hour. Then in a week, she's going to tell me to drop it down. And then she's going to tell me to drop it down some more. And then it's all going to be over and I'll be off the drops. Why am I going to see her? The reason that you're coming to see me is, number one, as we talked about, just, trying to get the management as tailored to what you need at that time as possible. But also because one of the complications of using these steroid drops is that in some people their pressure is going to get very, very elevated, their eye pressure. And elevated eye pressure is what we call glaucoma. And if elevated eye pressure persists without treatment, it's going to start to cause loss of your peripheral vision. And the peripheral vision starts to tunnel in to become very, very narrow. Now, when we look at countries where we don't have glaucoma screening, where we don't have good access to eye care, your average person presents to the doctor complaining of the problem when they're down to such a narrow window that they're already illegal to drive, for example. And so it's painless, it's slow, it's not particularly noticeable. So if you're at home using your steroid drops and your pressure goes up, you don't know. Now, most of the time, when you stop using your steroid drops, the pressure comes back down. But sometimes it stays elevated. It's actually triggered a glaucoma that's not going to go away. And so my nightmare, and I know a lot of my colleagues' nightmares, are iritis patients who've gone along and treated themselves for a couple of years, and they come in and their eye pressure is extremely elevated. And instead of their optic nerve having all this nice orange healthy tissue, it's got just a little bit left, and I know already without even doing the visual field that it's going to have become incredibly narrowed. And so, I get lots of patients saying, well, why can't you just give me, 10 or 12 of these refills? And I hate coming in here all the time. And that's the reason. The other thing is that the steroids can cause cataracts. You can see that that lens isn't black like the one we looked at in the other picture. It's white. And that person's not seeing out well through the cataract, and I can't see in well through the cataract. And that you will notice because your vision's getting blurry. But, and when we have to cause a cataract to treat the inflammation, we do it, right? We've got to get your eye healthy, and we've got to get the inflammation to go away. And cataract is something that we can deal with. We can remove it. But it's, again, another reason that we try and sort of monitor things. And what will be sometimes difficult is someone's using the steroid on their own, their vision's getting blurry, they're interpreting that to mean that their inflammation's worse, so then they're using even more steroid, and then their cataract's getting even worse. So having somebody else to check it out is important. So what if it doesn't work? So you come in and you've seen me, and you've had your iritis, and instead of doing what we hope it does, which is flare up, cause you a problem, and then go away, instead it flares up, and I can't get it to settle down. And maybe we try some oral prednisone, and it doesn't settle down. Once in a while, we'll inject steroid into the eye, and it doesn't settle down. If somebody progresses from what I would call an acute episode of iritis into a chronic iritis, sometimes we do intervene with different immunosuppressant drugs, methotrexate, cyclosporin, even some of the biologic agents that some of you are familiar with, Remicade and Humira, will be helpful in that case. And I do have patients where I have to do that. And that's when being able to have access to multidisciplinary forums like this and having colleagues in rheumatology, colleagues in gastroenterology, I get the benefit of saying, hey, I'm kind of on the fence here about this for the eye. What do you think? Would it help the back? Would it help the bowel? And we can kind of get together and look after you collectively. So if you're in a spot where you're on a medication for a long, long time for the eye, it's worth saying, hey, is there something else that would help suppress this inflammation, or do we have to keep attacking it topically? Okay, so that was all the information that I was going to present to you right now, but I will be around at the end, and if you have any questions, I'd be happy to answer them.
Thank you very much, Dr. Sexton. The next person on the program is another patient, Mr. Andrew Hobbs. Andrew was one of the founders of the spondylitis group in BC probably 30 years ago or so, and he's been a past president of the BC division before we had a Canadian Spondylitis Association. So, Andrew, we welcome you.
Anyway, I've been asked today to talk to you about my experiences of living with ankylosing spondylitis. And I'm an old-time spondy, just like Don. I was first diagnosed when I was 21 in 1965 in the UK, and I was lucky enough to see a specialist who was recommended through my doctor at St Guy's Hospital in London. And I guess the symptoms that I had then were, you know, the dull aches in the sacroiliac area. I didn't have any set stiffness at that time. And they put me on butazolidine then, which isn't used anymore. And it very quickly told me how important it was to get diagnosed very early on in this insidious disease. Unfortunately, I had to stop playing rugby, but I continued to play squash and tennis competitively, and all my life I've continued to do that up until about 18 months ago. And now I just play a bit of golf. I was fortunate also to be recommended to go on a course which was done through the British government down at the National Hospital for Rheumatic Diseases down in Bath. And this course was a 2.5-week tune-up course, basically. And what it did was it educated me at a very young age, at 21, 22, about the disease and what I could do for it myself. It told me the rudiments of the disease, the progression if I didn't exercise, and right at the very beginning, they took measurements of your mobility in the spine. My other joints weren't affected. But so they take the measurements right at the very beginning, and then they take the measurements right at the end of the course, 2.5 weeks later. And invariably, your measurement had improved. The mobility had improved, which was telling us that the bones hadn't calcified. The course itself involved bed rest, rigorous exercises, and education on posture, which was extremely important. And as you see there, prone lying was one of the things that I've done all my life to make sure that I'm not bending over. At that time, I also bought an orthopedic chair, and I've looked around the room and seen how a lot of people are sitting. It is important, if you've got AS, to always think of your posture, neck back, sit upright, you know, good lumbar support, and that carries over into the bed as well. In the hospital, the beds had no springs, plywood, and just foam rubber, and one pillow. So the essence was to keep you straight and stop you from bending over. The other thing that was critical in this 2.5 weeks was swimming and hydrotherapy in a warm pool. That's at blood temperature. And underwater swimming. And this was done, there was 12 of us, and this was done in a sort of competitive nature. And us spondies are generally very positive outlooking and competitive just in our nature. We're going to beat this disease. And it was just interesting in the underwater swimming. You started off, you just about do one length before you're absolutely breathless. By the end of the 2.5 weeks, you were doing six lengths, and you were fine. So there's the improvement. So I'm a great advocate of swimming, underwater swimming, and hydrotherapy exercises, very, very specific to the joint. You know, normal sports, like I've been fortunate in that I've been able to continue with tennis and squash, and now I still play golf. But it's the actual specific exercises for the joint that is troubling you that is important. The combination of the anti-inflammatory and the exercise is what's going to win you through. So the daily exercises and daily routine, early on, before or when I was being diagnosed, I would wake up early in the morning with the usual, this was 3 o'clock in the morning, with the usual dull ache that us spondies always are characterized with. And I'd fall out of bed and I would do the stretching exercises in order to relieve this, or try and relieve this excruciating pain, the dull ache that was just going on and on and on. And I very soon learned that the exercises in combination with the anti-inflammatories worked for me. The other thing that we were taught as part of our exercise routine was, after the rigorous exercises, which our physiotherapist, I mean, we called her the Gestapo, because she had put us through these exercises to an extent where she really pushed you. And you got to do a little bit more, and a little bit more, and a little bit more. And it hurts. It'll always hurt. You don't do it so that it's about to crack or whatever, but you do it because it's going to hurt. But if you do it to the extent that you've got it for one day, if you continue that every day, you will find that that movement will improve. And it's that sort of exercise that you have to do rigorously on an ongoing basis. And then afterwards, because you've set your muscles all in tension, you've got to have bed rest. Just rest and you just relax. Now, this slide actually shows the guy smoking, so you can see how old it is. Don't smoke, please. But relaxation after exercise is as important as the exercise itself. So you just get the tension out of those muscles. If those muscles have still got the tension, you're going to get that pain. Lastly, I married a lovely nurse with the understanding and the patience to weather my mood swings during the enduring pain, although doubtless my family didn't understand. Now I reckon that the disease has probably burnt itself out, although I take Arthrotec twice a day. I was chatting with Dr. Kayla earlier just now, because I take glucosamine, sulfate, and chondroitin, which he actually says does nothing. It's probably just a waste of money. And I've always thought that, and I've always believed that. But I do it because I don't have any pain anymore, which is wonderful. I had a hip yes? Can you move back towards the microphone when you move away? Oh, I'm sorry. Can you hear now? Okay, thank you for telling me. And so I just continue with what is working for me, and you know, that sort of treatment and regular exercise has been working for me all my life. The one thing in the early days that used to happen, actually, you know, if you're, and you probably you as spondies have experienced this, if you're suddenly jolted in a crowd like I was on a squash court when I had to win a point and somebody bumped into me. You had this excruciating pain, and I'd yelp. And, of course, the audience went, what the hell's wrong with him? But it won me a few points as well. Whether it was through AS or not, I had a hip replacement 12 years ago. It was probably through playing squash and attrition. I don't know. And I've got a bit of a knee problem, but it's probably wear and tear. So I've been extremely lucky in that I haven't had a lot of peripheral problems from AS. But the sitting position I can't emphasize enough, right? And I don't know whether they do orthopedic chairs in Canada, but certainly they make them in the UK specific to your size, and they give you a really good sitting position. So the message really that I'm trying to give today is that we as spondies, it's up to you. Yes, it's up to your rheumatologist to give you the right sort of anti-inflammatory that works, but it's up to you to exercise specifically for your joint problems. And the final message, the old adage, accept it rather than resent it. Thanks very much.
So if you do have questions, I'd invite you to jot them down, and perhaps Don, you and I can start to round them up, and so that we'll have questions. Or perhaps if you could pass them forward to this front table here gradually, and then we'll deal with the questions from all of the speakers as we go. So our final speaker this morning is Catherine McCauley. Catherine has been the senior physiotherapist at the Mary Pack Arthritis Centre for quite some time, has a special interest in spondylitis, and so as a physical therapist she's going to address the non-pharmacological aspects of the management of spondylitis. Welcome, Catherine.
So my objective today really is to discuss strategies and exercises that help minimize the impact of ankylosing spondylitis. And I'm focusing on the tack that I've taken is what is the impact of ankylosing spondylitis, and to look at each particular aspect rather than just think it's the disease and you're overwhelmed. Break it down into the different components and what can you do about each of the components. Is that speaker working okay? Microphone? Yeah, people at the back are nodding? Yeah, okay. So the key points will be posture, breathing mechanisms, stiffness in muscles and joints, weakness in muscles, fatigue and decreased fitness, and then pain. I'll spend more or less time on variations of them. So posture, which was mentioned before, is really critical. And it's the altered posture in ankylosing spondylitis is due to the natural tendency to stoop forward, to ease the pain, to open up areas where there's inflammation. It's often considered a position of comfort at night, or if you're sitting at the computer and you're leaning forward, it's an occupational positioning. And then the body mechanics that we talk about of weak muscles will go forward. So the strategies are to learn and practice best posture. So I would like everybody to sit up until you feel there's two little bones under your buttocks there. Okay, and good sitting posture should have, there, I can't take my jacket off. I can't demonstrate. Okay, so when you curve forwards, you'll roll off of those two bones that are called your ischial tuberosities, and you're more sort of on if you let yourself slump forwards, you're off of those, and you're more on your tailbone. And then if you roll your pelvis to arch your back, then you're again off of those. So if you roll back and forwards to sort of feel that you're on those bones and you're off those bones, the right sitting position is to be on those two bones. Those are your sitting bones. That's what they're designed for, and it sets the pelvis at the right position. Okay? And you want the position, the posture, evenly on both, not more on one or more on the other. So when that is the foundation that the rest of your spine sits on. Okay? So for posture, you want to learn and practice that best posture. From there, the tummy is in, the shoulders are back, and the chin is tucked in. Okay. So this just demonstrates normal standing posture. You want your ear, okay, to be aligned over your shoulder, not in front, but over the shoulder, and the shoulder over the line of the hip and over the knee, so nice and straight. That's what good posture is. Okay? Also, the fact when your head goes forward, there's more work on all of the back muscles because of the effective leverage. So sitting posture, keeping the neck tucked in. Okay? The types of things that I use to describe it are to imagine that you're Pinocchio, you're a puppet, and you're being pulled, that back part of your head is being pulled up. Or another way, at the same time, imagine that somebody that you really like is coming to talk to you intently, but they have bad breath. Whoa! Okay? So get that chin and that head over your shoulder and tighten up. Okay? And be aware of your posture in those positions that you spend a lot of time in. Okay? Okay. So one of the other impacts of ankylosing spondylitis is not just on the spine, but the ribs attached to the spine. And the ribs, each rib is like the handle of a bucket. And when you blow out, it goes down. And when you breathe in, it rotates up. Okay? So a breathing exercise, I'm honestly going to have to take this mic off because I can't demonstrate with my jacket on, and I will put it on my other collar. There's an exercise I want you all to try now for breathing. Okay. If you can reach your hands to the side of your ribs, you can do that. If not, grab your shirt on an opposite side. Okay? As you blow out, feel the side of the ribs go down. And as you breathe in, feel the pressure either out against your shirt or out against your hands. Okay? So that's what we call lateral costal breathing. Okay? And that's where those ribs attach into the spine at the back and into the sternum at the front. There's that rotation. And so you want to maintain that movement. Sometimes a bathrobe strap crisscrossed around will help you really be aware of that. So again, as you blow out, feel it tighten, get smaller as you breathe in. Your ribs expand out to the side. Okay? So that's one type movement that you want to keep going, is the breathing pattern. Okay? The other thing that happens if you let the ankylosing spondylitis pull you forward, it makes the rib cage smaller. Okay? So this rib cage is smaller, and the heart and the lungs have less space when you're bent. Also, if the ribs can't move, there's less space in there, and it decreases your vital capacity, so you have less energy for playing squash and walking and swimming underwater. Okay? So stiffness in the muscles and in joints can occur when you're staying in one position because of inflammation that occurs for poor posture. If muscles are allowed to tighten up at the front, the muscles at the back have to work and they can get into spasm. And so if you look at those as strategies, okay, is my pain and stiffness coming because there's inflammation? Then I might want to try some ice to bring down some inflammation. Ice packs to the lower back or to the areas that are sore, the back of the neck. Learn and find ways to maintain that optimal posture that we talked about. Stretching exercises to open up the front of the chest and the front of the hips. Standing in a corner is one. You saw lots of good exercises there, but learn about those exercises that stretch the front of the chest, that stretch the front of the hip. Can you see me through this poster, or do I need to move over here? Okay. So like stretching the front of the hip as well as into the corner stretching, and lying on your stomach will also give a stretch to the front and a strengthening, which is the next point. Okay. If the stiffness is because of muscle spasm, then you want to look at maybe some heat, some massage, that type of thing. So if you try to break down what are the issues and deal with each issue specifically, it can be helpful. Weakness in muscles can occur because of avoiding exercise, because it hurts, it's painful, or that you're just too tired, because this disease just creates so much fatigue. Or there can be depression that's a separate condition, or just you're depressed because everything hurts and you're having difficulty sleeping. Okay? So when you strengthen exercises, you can do them, but it's important that you progress slowly. With exercise, especially strengthening exercise, if you try to push your exercises too quickly and you say, okay, I'm going to exercise and I'm going to go do this, and then you're really sore and painful afterwards, then you're just going to convince yourself that you can't exercise. And so for all types of arthritis, it's important that when you start your strengthening exercises or any exercise, that you start slowly and gradually, and that you identify what it is that's stopping you from exercising, identify your barriers, and then try and deal with those. Fatigue and decreased fitness. The fatigue can be part of the disease process. What I've explained to some people is if your friends or neighbors have the flu and they're exhausted, then you say, okay, that's your immune system working and you're exhausted because your immune system's working. Well, my immune system's working all the time. That's the fatigue that I feel. And so it's really just that no energy to get up and get moving. And then the less you do, the more deconditioned you become, and it becomes like a whirlpool that just kind of sucks you down. Also, if you're not sleeping well, we all know that it's really difficult to exercise and move if we're not sleeping well. And then if things have gotten tight and we have less vital capacity in our lungs, those are all issues. So the strategies for fatigue that are recommended by the occupational therapists are pacing. I really liked that the speaker before talked about after exercise to rest. If you rest before you're exhausted, you'll be able to get up and do things again. So that's important. Identify the barriers. What is it that's causing difficulty sleeping, and can you find sleeping positions where they're straight but you're comfortable, and what are the other things that are causing difficulty for sleeping? The breathing exercises, and then fitness and aerobic exercises. Okay. So pain is, I've left to the last because it's another one that I wanted to spend a little bit more time on. Pain can come from inflammation of the joints, of the bones, or the entheses. Pain can be there from muscle spasm. It can be there because the ligaments are being stretched, joint capsules are being stretched, or muscles are being stretched. In an end stage, if you've got osteoporosis, which later stages is not that uncommon, then you can have the compression fractures of the bone, or physical changes in the central nervous system. So the changes in the central nervous system, in the way the pain gets transmitted to your brain, the researchers are learning more and more about that now. And I kind of relate it to a musician will hear more fine tunes and notes in an orchestra than I can. My daughter plays trumpet and piano, and she'll say, oh, listen to that, and I can't hear what she's talking about. I have not trained my ear to hear. And so she has changes in her nervous system that make her more alert and more sensitive to those things. The brain is so fabulous. I grew up, my dad was a pilot. I grew up near an airport, and family would come from out of town, and the airplanes would be flying over, and they'd say, how can you live with all this noise going on? And I didn't hear the planes because my brain had decided to tune that out. Just like if you live on a noisy street, it bothers you at first. Well, the brain can do that with pain, too. And if you're worried and anxious and you're thinking this is a disease I have no control over, your brain will open up more pathways and more gates in the system and transmit small sensations into pain and create pain sensation. And so the strategies are to learn about chronic pain, to learn what changes occur in the nervous system. It's very real pain, but there are physical structural changes that occur in the nervous system. And so learning about pain management, trying meditation strategies, trying relaxation, acupuncture, also the transcutaneous electrical nerve stimulation, the TENS machines, are also strategies that can help with pain control. Okay. And recreation and leisure are ways that you can try and incorporate these strategies into daily living and into fun things. So the swimming, yoga puts you into positions that create the stretching positions and the strengthening positions. The fitness centers have equipment that can be used. There's various dance styles that really emphasize a lot of straight posture. Many options. So it's important to find the things that you like to do. How often do I exercise? It varies on the type, but the stretching and the range of motion should be done every day. And the strengthening should be done alternate days. If you push yourself in a strengthening exercise to the point of fatigue, or, oh, that's the last time I can lift up, or that's the last bend that I can do, then that is best done every second day. You can do it every day if you're not pushing it quite that hard. Okay? And aerobics, they used to say 30 minutes 3 to 5 times a week, and now which is basically your optimum, is to do at least 30 minutes at least 5 days a week, but you will continue to get added benefits up into an hour a day. If you exercise more than an hour a day, you won't live any longer, but if you want to exercise 2 or 5 hours a day, that's okay, like an athlete, but the research has shown it doesn't increase your life expectancy. But the things that are important for everyone else are just more important if you have ankylosing spondylitis. Okay? So just to summarize, the target areas are to stretch the anterior chest wall, your neck posture, stretching the back here, to strengthen the upper back and the lower and the hips, and then to stretch the front of the hips and the Achilles tendon. And so try to find a recreational activity that you really love, and that gets your heart pumping and that gives you enjoyment. These are the recommendations. And so I wanted to thank my colleagues and thank the clients who have shared their experiences with me and shared their ideas as well, those who have ankylosing spondylitis. So,
what I'd like to do is invite the speakers to come up. We may be a little squished here, but we'll grab a couple of extra chairs, and then we have a hand mic that we can pass between people. Dr. Flanagan, Dr. Kaler, Dr. Sexton, Andrew Hobbs, Don Binden, Catherine. Come on in. So Don has sorted out some topics relevant to the particular speakers. So we'll do some round robins here. If Dr. Flanagan would like to bite off. Test. So we're going to invite Dr. Flanagan to start, and I'll give her this hand mic if she would like to elect to answer one of those from her array.
I know there are lots here. Okay, so one of the questions is about anti-inflammatories and cardiovascular disease. So it's a big topic. As everyone knows, there is a slightly increased incidence of heart disease with anti-inflammatory use. I know that sounds somewhat counterintuitive when you say that they may decrease cardiovascular use in these diseases. The issue really is if you have underlying cardiac disease, then you are definitely at increased risk. So if you have a history of heart disease, it may not be a great idea for you to be taking a regular anti-inflammatory, and it should probably be assessed by your general practitioner or possibly a cardiologist. For people that are otherwise relatively young and healthy with no underlying risk, the chance of developing anything is pretty small, and it isn't as much of an issue. So it does depend on the situation. We do know that in patients who have ankylosing spondylitis, as we were saying, that they do have an increased cardiovascular risk. So controlling all of the usual risk factors, such as high blood pressure, not smoking, exercise, cholesterol, all those types of things are probably the most important thing. And it's something that you should discuss for sure with your general practitioner and definitely with your rheumatologist as to whether it's a good idea for you to be taking an anti-inflammatory. So hopefully that's going to answer the question more or less.
I've just got one little follow-up. Whose job is it going to be to run this cardiovascular program? Is this going to be the role of the rheumatologist to follow the lowering of cholesterol and lowering of blood pressure, or does this become the are you going to recognize it and then want the family doctor to do it, or who's going to run it?
It's something that has to be done in, I guess, as a team. But we are more and more as rheumatologists, we are screening for, we're checking blood pressure, checking cholesterol, blood sugars, and so on. We don't have the time or resources to do all the follow-up for that, obviously, but we certainly do ask the GP to be involved and do help to monitor it. So it's something that is, as I said, a team approach. And we're making patients aware of it.
Some of us last week were in Berlin at the European arthritis meetings, and through that whole meeting I'd never heard so much information about the incidence of cardiovascular disease with respect to spondylitis. So having been around the world of spondylitis for a long time, this is somewhat relatively new focus.
But we also know that the biologics, it hasn't really been looked at as much in ankylosing spondylitis yet, but in rheumatoid arthritis, there's no question that the incidence of cardiovascular disease is coming down significantly with the use of biologics because we're being much better at controlling inflammation, which is the underlying reason for this, basically.
Dr. Sexton, do you have a question you'd like to address there?
I'm happy I know the answers to all of mine. The question is, can ankylosing spondylitis cause cataracts? No. If you have iritis and you have unchecked inflammation, you can develop cataracts from the inflammation. If you have iritis and you're treating with steroid, the steroid can induce early onset of cataracts. But in the absence of iritis, there's not an increased incidence of cataract just from ankylosing spondylitis.
Good. Dr. Kaler?
I don't know all the answers. You're smarter. A couple of questions on diet and why did we not address the question of diet? Why is there not more research being done? In fact, there has been research done over the years on diet. It's a very tempting area thus far. Research on dietary manipulation, adding in, taking away, has not been shown. We've never been able to demonstrate any efficacy for that, as has been the case, in fact, in most inflammatory diseases. Might there be something? The answer is possibly. These are difficult studies to do. It's very hard to take a few thousand people and put them on very structured diets and ensure they'll stick to them. Heavens, you don't even stick to your bloody exercises. So, but I point out that you'll often read stuff. Dr. Google will tell you lots of things. The reality is, when I was a medical student, that was before you were a medical student, Kathy, we all knew that diet was responsible for peptic ulcer disease. We all knew that. It was diet, and you were stressed. Those were the things, and we all knew that. That was the teaching, and that was wrong, because there was a little bug called Helicobacter pylori, and that was responsible for a substantial incidence of peptic ulcer disease. And guess what? When I was a GP, some of the time I spent in the OR was to operate on people with peptic ulcer disease. Not me. I was the assistant. But the reality is that virtually never happens anymore. Why doesn't it happen? Because we really have found something significant and a very causal relationship. So might there be a dietary event that or manipulation that might help? Maybe, but I tend to be a bit skeptical.
I have a couple of questions about that too. There hasn't been a lot of research in ankylosing spondylitis, but in rheumatoid arthritis, it's been shown that the Mediterranean diet, they actually did a study that got published, I think, 2 years ago, where they looked at different diets, and the Mediterranean diet was the one that was the best for controlling the inflammation. And in rheumatoid arthritis, again, you can't always extrapolate, but red meat was found to make the symptoms worse. We do know that the omega-3 fatty acids have been beneficial in terms of helping inflammatory arthritis and heart disease, so it's definitely worthwhile to go with your omega-3 fatty acids, whether hopefully through your diet if you can, with fatty fish. If not, you can take supplements. And again, in rheumatoid arthritis, a little bit of red wine was found to be beneficial, so it's not a bad thing as well. And it's good for heart disease, as is dark chocolate. So there you go.
Before somebody at the back asks, would you like to comment on starches? There's an entire website devoted to that particular topic of the relationship of starch and its facilitating the flora of bacteria in the gut. Does anybody want to comment on? Dr. Kaler is looking.
Again, getting a website full of poor research doesn't constitute information. The reality is that the well-designed studies have not supported this. So it's the old issue. People will talk about, oh, well, I saw this, and it was published, and it was a doctor. And so that must be right. And my commentary is that having an MD doesn't stop you from being a damn fool. So
one of the things over the years that I've seen is various people have tried these diets, and whether there's validity or not, if you try something and it works for you, go with it. That's a little different from then advocating it for the next 99 people who should do what you found to be successful. But if you've eliminated something or added something to your diet and it seems to work for you, then your study of one is valid for you if it doesn't apply to others.
So I have a question about biologics in patients who have inflammatory bowel disease. I mentioned that all the biologics, so etanercept, adalimumab, infliximab, and golimumab, which are the ones that are available to us right now, basically are equally effective in terms of treating the arthritis. But it is true that there is a difference. So etanercept, which is approved for ankylosing spondylitis, does not treat inflammatory bowel disease. It also isn't quite as effective for psoriasis or for uveitis. So in patients that have those extra-articular manifestations, they would be on usually either Humira or infliximab would be the two that would be most commonly used. So I think that answers that question. And we had a couple related to that, right? Oh, and somebody asked a question about whether methotrexate increases the effectiveness of these biologics. That's very definitely true in rheumatoid arthritis. This is a somewhat controversial topic because it had been felt from studies that methotrexate wasn't of benefit in the use with biologics in ankylosing spondylitis. But again, in Berlin just a couple of weeks ago, there's evidence that you can develop antibodies to some of these, something like adalimumab or infliximab, and there does appear to be, in some cases, the drug doesn't work as well because of these antibodies, and adding methotrexate can prevent them from happening. So there are some cases where we would add methotrexate and it would affect, but that's not in the majority of cases. And that is true, though, in psoriatic arthritis, that we do use methotrexate with these drugs.
I had a question if there's any link between uveitis and glaucoma in patients with ankylosing spondylitis. So uveitis itself doesn't tend to cause glaucoma. It actually tends to cause low pressure because the ciliary body, which makes the fluid inside the eye, isn't working very well. But the worrisome side effect of the steroids in iritis and uveitis is that it can put the pressure up for most people just while they're on the steroid, but in some people they go on to have prolonged glaucoma afterwards. But if you have ankylosing spondylitis and glaucoma in the absence of iritis, it's just a coincidence.
Could you pass it down? Catherine has a couple of questions.
So there's one question that says, does yoga help ankylosing spondylitis? The person says they have a very rigorous and regular yoga practice, and the person is wondering if it worsens or helps the pain. It seems to help posture and stiffness. And generally, physiotherapists do encourage yoga, particularly in the early stages and then continuing. If you are in an advanced stage and you already have ankylosing, then you may have difficulty starting yoga at a later stage. But if you're able to do yoga, yoga is one of those types of exercises that really balances. There'll be positions where you're bending forward, so you'll be stretching the back muscles, and then proper yoga instructors will always do an opposite position, so there'll be an arching backwards where you're stretching the front muscles, and there are strengthening poses. And it also includes a relaxation component, some breathing instructions, and sort of that meditative component, which also helps with the pain centralization or the pain amplification. So it includes strengthening, it includes flexibility of the spine, it includes breathing, and includes relaxation. So it's one of those that is generally comprehensive. In ankylosing spondylitis, usually you have more pain with rest and less pain with movement. Because there's inflammation, you're mechanically pumping the swelling out. So movement is generally better, would be advised. Do you want me to answer the other one?
Why don't you do the other one as well?
Okay. So the other one is, what type of bed should someone sleep on? Foam or regular spring, and should you sleep on your back or on your stomach? So you should try. Sleeping is a position that you are in for a prolonged period of time. So sleeping on your stomach, or completely on your back, keeps you straight as long as you're on a firm mattress. So you don't want one that sags. If you're sleeping on your back and you have a saggy mattress, you're not going to be keeping your spine straight. So it needs to be straight. The other thing is, though, if you have a lot of bones, a lot of pain, you probably need some cushioning on the top of it. So it needs to be firm with cushioning. It needs to be comfortable. Sleep is very, very important. So I recommend that you get information about all the types of things that influence your sleep and that will increase the chance of getting a deep sleep, as well as your mattress. Sleeping on your stomach will help keep you straight, but you have to be careful of the position of your neck, because you might be turning your neck more to one side or more to the other and aggravate neck problems there. So be aware of that. But trying to sleep straight, back or stomach, can be fine, or just even resting on the stomach for prolonged periods of time during the day, so that you're making sure that you're staying straight. So firm but comfortable.
There's a difference between firm and hard. People sometimes think, if you want to ask any soldier who slept in the war on a board floor, I mean, there's no merit in that. So these days, beds that are, inner spring mattresses and so on, they're firm, but they have a little bit of softness to them. So we're talking about trying to keep things aligned. There's no merit in a bed being rock hard. I mean, it's so you get the nuance between firm and hard. Yeah.
Unless it has nails in it.
Pardon?
Unless it has nails in it.
We're not talking about acupuncture here.
So when do you guys, I can't remember who talked about first hearing your diagnosis and saying a name with that many syllables can't be good. But there is a benefit. I have to tell you a little anecdote. My old secretary, so some of you may know from the Arthritis Center, Marie Weir, was called by a family doc in the Kootenays who was anxious to hear my consult, which Marie had just typed but hadn't sent out. And he said, well, can you just read it to me? And she said, well, okay, but hold on. How do I know you're a doctor? Spell ankylosing spondylitis for me. So someone who's on Enbrel was wondering when they would know that the disease had burnt out. They were presumably doing well with the Enbrel, and so how long do I need it? And my answer in that setting, as it is for rheumatoid arthritis, is I don't know. There's no way of telling, by and large, except by stopping the agent and finding out. I do tell people that if the worst problem we have to face in the next several years is I'm doing so well, I wonder if I need my medication. That's not so bad. And if you really desperately want to get off the treatment, for no other reason than you just want to be off the treatment, then I call it your Clint Eastwood moment. Are you feeling lucky? We don't know. We do know that there's a Toronto cohort of the guy who I showed you the picture of. A large group of those were followed from the late 1940s when they mustered out of the army on through into the 1970s. And a significant percentage of those guys went into remission. Their disease burnt out. But there's no way, there's really no way of predicting that or evaluating it other than that you're off all the treatment and you're doing well. So it's a bit of a crapshoot.
I got a couple of questions about that as well. And we do know that these drugs work while you're taking them. They don't cure the disease. So as far as we know at this point, you sort of need to keep on taking them long term. There have been recently, and we saw this in Berlin as well, a few studies where they have tried to taper or decrease the frequency of the medications or try stopping them. And there will be a small percentage of people that will be able to stay off the drugs. This seems to be more in people that have started them early. So that's something which is being assessed and looked at because we're not 100% sure. The issue of burning out, there have been studies that have shown that even people that were, quote, burnt out, still had benefit from the drugs. So I don't think there's ever a time when it completely burns out. But obviously symptoms can decrease, especially when somebody has lost most of their mobility. There was a question about side effects, whether there was a difference between men and women, and basically no, not really. And in terms of the balance between side effects and benefits, obviously, if you can get people back to work, and some studies are showing a significant improvement in getting people back to work, and so cost effectiveness from that point of view, and obviously decreasing pain and quality of life and so on. But there's also very significantly the benefit in terms of because the main reason why people may have a shortened lifespan is because of cardiovascular disease. So if you're making a significant impact in terms of preventing cardiovascular disease, that is really probably going to be one of your most important benefits.
Dr. Sexton, there's a number of a limited number of ophthalmologists in town. Some of them do cataract, some of them deal with retinal disease. How does one find the right sort of eye person to? Is there a way to find your way to the right place?
I guess I'd say first of all that any general ophthalmologist can treat iritis, and so there's no such thing as a cataract as a specialty. You know, that might be somebody's interest, but they're certainly well trained to deal with iritis. Okay. There's a website, it's BCEPS, bcseps.com, and that lists all the ophthalmologists in BC, and if they have subspecialty interests, it lists it there, so you can see that if somebody's practicing general ophthalmology, then they'd be a good resource, and hopefully your family doctor would have a good idea of where they send their patients.
I think often the problem is the family doctor says, oh, you'll never get into an ophthalmologist. This is far too long. So I tell my patients, look, here's this problem that you may have. If you have a single sore red eye, you have to think it's probably iritis until otherwise proved, and you have to see an ophthalmologist. So you have to be obnoxious if necessary. And if someone says, oh, just take this, it's probably an infection, just use these drops, and if it's not better in a week, come on back. I say, you can't do that. You have to be obnoxious. You have to say, no, my rheumatologist is a really irritable bugger, and he says I have to see an ophthalmologist. And there is no ophthalmologist, I believe, in our country that, given the story that I have a patient with spondylitis and a sore eye, won't see you immediately.
So it seems that, do you have any more questions in your...
You're kidding.
You've got some more?
Yes. Someone asked, is there any research or cure for fused joints? And the answer is, to the best of knowledge, I'm not aware of any active research going on in that. Clearly these are joints that have bony fusion for the most part, so it's a difficult area to reverse any more than you could reverse your forearm and have it develop a joint in the middle. the reality is about the only thing that you can do, and I hate to say this, but if you've really got a bad flexion deformity, say in your neck or actually even in your back, you can have surgery, and that's big stuff where they actually can straighten out the spine. It is major surgery, and it's done in a very limited fashion, and it does require very subspecialized surgeons to do that. But that's, to my knowledge, the only thing that's possibly can look at fused joints.
There is one particular orthopedic surgeon who was specifically trained in the management of spinal correction in spondylitis, and he was trained by Dr. Simmons in Ontario, and his name is Dr. Dvorak, and he has a special interest in the management of spondylitis and has done several spinal osteotomies to straighten people up who are really bent.
Scary surgery.
But this is relatively uncommon, and I would imagine that most of the people that he's done are people who have had the disease for many years, and if you develop spondylitis these days with the better management and earlier recognition, that I think that's going to be becoming something that will not be needed in the future, fortunately.
And I think that leads to one of the other questions was about pulmonary fibrosis, aortic stenosis, and one I'm not sure about handedness, left-handedness. Anyway, I can address the first couple. Pulmonary fibrosis is recognized as a feature of some people with ankylosing spondylitis. It's rarely clinically important, but it is there, particularly up at the top of the lungs in the apex. Aortic stenosis, but actually more aortic insufficiency. The aortic valve, when the ring around the aortic valve gets stretched out, is a known complication of ankylosing spondylitis, and some of that research came out of Toronto with Hugh Smythe. You do see it very, very rarely these days, and that leads to that point you've just made, Bruce, about I think the earlier we treat these inflammatory diseases, the less we're going to run into these serious visceral problems. But I think I've seen one in the last 10 years, so it doesn't fortunately occur very often.
I got a question, but is there any research into Lyme disease and ankylosing spondylitis? Not that I've seen. This is a bit of a can of worms. Lyme disease, as you probably know. We do have a little bit of an incidence here, and I believe that Coastal is supposed to be opening a Lyme arthritis clinic. So what I've heard in the next year or two. So, but that's basically all that I could say about that at this point in time. I think that's about it. Oh, and somebody was asking about pregnancy. Most of the inflammatory arthritis actually get better during pregnancy. And I mean, obviously, if people are having back pain and stiffness, that may be a bit of an issue, but there shouldn't really be an issue in terms of pregnancy and ankylosing spondylitis.
Sounds harsh anyway.
Do either of you want to, Dr. Kaler or Dr. Flanagan, want to comment on the use of medication during the term of pregnancy?
I think by and large, we don't think biologics are, we don't know that they're safe in pregnancy, so basically we say you shouldn't use those during pregnancy, never going to have a control study. As with every other drug, there's going to be enough people over the years that keep on to conceal their pregnancy that we'll find out in an indirect, rather unscientific way about this. But for the most part, my advice for my young women with arthritis is we want to keep you off as much medication as we can during your pregnancy. So don't come in and say, I'm 3 months pregnant, because that's not a good time. Plan your timing. We'll talk about the medication. We'll talk about what is definitely not safe, what is possible, and go at it in an organized fashion. And by and large, it works just fine.
This is a subject in rheumatoid arthritis that has a self-regulating mechanism, and that many women with rheumatoid arthritis, they tend to get better. They have a remission during the time of their pregnancy, so often don't need medication and do well. Unfortunately, that doesn't hold true generally with spondylitis.
I had a lady who did so well with rheumatoid arthritis during her pregnancy. She said, gee, I wouldn't mind always being pregnant if it weren't for the byproduct.
is there a case to be made for a natural substance like steroid during the?
Oh, I believe that, in fact, that's probably our safest agent. There's some little bit of data to the contrary, but for the most part, it is truly a totally natural substance that your baby's exposed to all the time. And if you've got to choose one drug to utilize during pregnancy, that's my drug of choice. There's one other thing just about weather. Does weather have an effect on arthritis, particularly Yankee-Spawn flare-ups? Well, but it's true for almost any kind of arthritis. That question comes up. And, of course, how many people feel they're weather sensitive? And is it particularly wet weather, cold weather? That wet? Okay.
Changing weather.
Yeah. So there was a classic study done by a guy called Joe Hollander, who was sort of the grandfather of North American rheumatology way back in, I think that was in the 50s, where he put people in a climate-controlled chamber and adjusted in a blinded fashion the humidity and the barometric pressure, and generally felt that people were, as Bruce said, were particularly sensitive, some people, to the change. There have been some population studies, one out of Saskatchewan, that didn't support that as much, but again, population studies are tough. These studies are tough. So the answer is, if it happens, it happens, and But the other side of the coin is often people feel, therefore, if I'm living in the Lower Mainland, I'm going to have worse arthritis than if I'm living in the Okanagan. And that's not the case. It doesn't make your arthritis worse. There are a lot of really busy rheumatologists in the Okanagan. There's a lot of really busy rheumatologists in Arizona. And when people say, should I move because of my arthritis, I say, well, you'll just have arthritis among strangers.
I think we've dealt with most of the questions, so I thank you very much for your attendance. I'd just like to acknowledge a couple of people. I'd like to acknowledge the Arthritis Society, who helped co-sponsor our event. Joan at the back is waving her hand there. I'd like to thank my wife, Jenny, who in our office was dealing with registrations for the last few weeks. And I'd like to thank our single sponsor, Abbott Pharmaceuticals, for making our room, our breakfast, and so on all possible today. And I thank you very much for attending. I encourage you to seek further information through the Canadian Spondylitis Association website. And as I've said to you, this is still it's on the way. It isn't where we want it to be. And in the interim, probably there are two websites that I think contain very sound information. There's the Arthritis Society website. There's also a website called spondylitis.org, which is the American Spondylitis Association, but you'll find excellent quality, vetted information with all respects to medication and the diseases and their management. And also there's for Andrew, you might want to go to the National Ankylosing Spondylitis, NASS, NASS, nass.uk would it be? Or? So it's NASS. The National Ankylosing Spondylitis Society is the British version, and it has very sound information. So spondylitis.org in the United States, nass.uk in the UK, and we hope to be bringing our own Canadian spondylitis website along over the next 6 months.
Bruce, one other website is Room Info, which is not specifically Yankee Spawn, but it's a website developed by one of our colleagues back in Ontario at the University of Western Ontario. Good information about drugs.
That's Andy Thompson's.
Andy Thompson's site. So RHEUM info, all one word, and it's fully accessible. There's no passwords or anything of this sort, and the information is accurate and up to date.
Oh, yes, Jenny's just asking, would you mind completing your evaluation forms, which were part of the package, and perhaps just drop them, just leave them on your table or drop them at the front door as you leave. So thank you very much for attending. Good. You got a busy weekend? Yeah.